1, 2, 3, 4, 5.
I can support that
I'm
that
from
rush.
Louisiana. If we can get an alien, I'm gonna put him in a gumbo.
Well, if a good old boy from Bentonville, Arkansas, can go sit in Nancy Pelosi's office,
Yeah.
anything is possible. What can I
Jesus,
say?
Jesus
Uh,
Christ.
Hey, just one deal on the SARS deal. They have not, last thing I read, and it was just a couple of days ago, um, their zoonotic or whatever they call that, where they're crossover, they do not say that this is a bat related disease. They say it is very similar to one that they noted, the COVID virus noted in bats. And so they haven't actually even made, because I mean, everybody says it came from a bat they ate or whatever.
Yeah.
And they've really not proven that the transfer point has not been proven at all anywhere where it
No.
went from animal to human. And it isn't a bat one, it is just extremely closely similar to a bat one.
I'm I'm about to say Gene Simmons been eating bats for years, and this ain't happened. So
Ozzy, I mean, if this was going to happen, it
I
would
was
have
gonna say that was
happened in the
Ozzy.
70s.
oh my God.
Right.
okay. And maybe it was around in the 70s and we just didn't recognize it as infectious disease as we have gotten better at recognizing some of these things and reporting them.
Well,
I think that's
how
the
many?
only. Go ahead, Brian.
No, I just say, how many people did you hear about last year at this time? I mean, almost exactly at this time last year, who had, well, I don't know what you got. You test negative for the flu. You test negative for the flu B. You got some virus, but we don't know what it is. I mean, I do believe it was going, not to be a conspiracy theorist, but I believe it was going on for a little while before
We
we
recognized it.
recognized it as a COVID virus. I
Yes.
believe maybe even to late fall of what would that be, 2019 is probably when we may have seen it, because I just know some people who were extremely sick and were told, well, you don't have the flu, but we don't really know what you got. And
Congratulations.
yeah,
So
and
You've got
so
an emerging infectious disease that we're tracking and trying to figure out what it is.
so Brian, do you remember Jerry Lester?
yes,
Did so last January, early, it was late December last January. He was actually intubated for about 8 or 9 days at a hospital in Central Arkansas for an
nobody knows
unknown
why.
illness. Nobody knows
Exactly.
why. Unknown illness. They ran every test they could. They said they don't know why. And then a day before he came off the tube, his wife was put on the tube for about 5 or 6 days because they just did
Interesting.
not. Yep. Because she did have some same thing happen to her.
Okay, let's go back to your point you were making a while ago,
Yep.
Boomtown, about
Yep.
the could
Boomtown.
China be found? If this come out of a lab, you know, could they be found? Yeah, they could be. They could be held for reparations, and it could go through the World Court. It might go through the UN. It might go through, there might be economic sanctions on them. We might not be able to buy stuff made from China, which would basically take care of everything we have in our houses. Um,
Yeah.
the but yeah, they could. But you got to understand, we're our robes are not clean either here in the United States. Why
No.
in the world does the United States keep in Atlanta, Georgia, in a suburb, in a building of CDC, the only active smallpox virus held in the United States? The United States has it, Russia has it. Now, why do we keep that? If it's been eradicated,
Bio
why do we
warfare.
keep it?
Bio
So,
warfare.
yeah, there you go. Some of it is biowarfare, and you can go and look at some of our military monies that we are spending. Yeah, we're doing Space Force. Yeah, we're doing this. Yeah, we're doing that. Do you remember the movie Andromeda Strain?
No.
Yeah. Well, it was about a spacecraft that went up in space looking for a virus or a bug to bring back to Earth to be used as a bioweapon.
Hmm.
Gene Roddenberry book, a very good book. If you happen to see the old movie, it's a good one. Anyway, let's go on and get this finished up. Yes, there are new infections coming out of geographical areas. We've seen that, but we've got higher epidemiology reporting. We have higher, and I agree with you that this may have been around earlier because people have gotten sick for weeks and weeks and weeks. But it's because people got sick like that that made the epidemiologists scratch their head and go, okay, let's do some what is that, contact tracing? Yeah, that's got to be big now. Big bucks in it too, by the way. So they're doing some of this stuff and they're keeping it going, and that's what we're going to see as we go forward. Yes, I think masks are here to stay. Yes, I think hand washing is here to stay. I mean, how many of y'all would have thought about washing your hands or using an antimicrobial on your hands, alcohol cleansing lotion stuff on your hands after pumping gas? I never thought I would, but I sat and listened to a guy when they traced back the only contact he had with anything was a gas pump. So if a gas pump can transmit this stuff, I'm going to definitely clean my hands afterwards because I don't want it. Am I going to get the vaccine as soon as I can? So, and when I get the vaccine, am I going to throw my mask away? No. Am I going to go back to doing things socially? No. We have learned there's things we've got to do to keep ourselves safe and healthy. There you go. So as we get to this point, we are ready now to take a break unless there's anybody that has any questions, any comments. And I need to grab a screenshot of this before y'all get out of here.
Hey, this is Jake.
Jake, go ahead.
I think walk into a doctor's appointment, so I may or may not be on that break. But I'll get back on when I get done.
Okay, I've got 9. Hey, thank you, David, for smiling. That was pretty. Chrissy will like that. And he's got one of those ba-da-ba-ba-ba. Do you see that, Brian? He's drinking a ba-da-ba-ba-ba. He got a large sweet tea. Is that large sweet tea?
I just want to know if he brought enough for the rest of the class, because that's how that crap's supposed to work. If you bring one for you, you're supposed to bring enough for everybody.
That's how we spread the virus.
Oh.
That too.
David, this is going to sound weird, but I have the exact same shirt.
Oh, are y'all Twinkies? See, I got my Stand Proud with NAMT on today. So I'm flying the colors. All right, we're going to take a 10-minute break for refilling coffee mugs or getting extra water or whatever. Let's come back at about, what do y'all think, 9:15? Let's come back 9:15.
Sounds good.
Thank you, guys. Yes.
Okay.
Do you want me to? I mean, I can come back in, but I'm gonna have to leave shortly after that for my dentist appointment. Do you want me to come back in, or just wait till I get back?
Wait till you get back.
I'll when I
It's
enhance,
also
stimulate, or more for gratification purposes, but it also is used or was promoted for a while in use of respiratory issues.
It's also used for AFib.
Really? And I had not heard that at all.
It's the irregular heartbeat and frequent clotting factors in people that have AFib. They would give it for women.
Huh.
Now that is brand new to me. I did some research on it and didn't see anything on that. That's interesting.
We picked a lady up at the Boston Mountain Clinic in Marshall, and she was taking Viagra. And I asked the doctor why she was taking Viagra, and that's what he told me.
Huh.
But she had been taking it frequently, and they were giving her nitro, and her pressure was dumping. So I was kind of combating that at the moment.
Ah.
Yeah.
What other analgesic? We give aspirin, right?
Mm-hmm.
Aspirin's an analgesic, right? Non-steroidal anti-inflammatory.
Not a lot of people know this, but aspirin starts to work immediately as soon as it hits the tongue.
Okay.
Chewables,
Any side effects with that? Any contraindications for that?
For aspirin?
Yeah.
GI ulcers.
GI bleeds. Good. What else have we got in our analgesic toolbox?
Morphine.
Well, there's a good oldie, but a goodie. And, of course, it's indicated in what?
Patients that's pain is not relieved by nitro.
Okay. We're talking about cardiac patients here, of course.
Yes.
Any other reasons for giving morphine?
Oh, trauma, obviously.
Burns? How about heart failure?
Yeah.
Say heart failure. Relax.
Yep. Any contraindications for morphine?
Hypotension, allergies.
Okay. Morphine also causes something with the respiratory center. What is that?
Decreased respiratory tract.
Yeah, it does. And now this new thing that you guys give, what is that? Starts with an F. Fentanyl. Is that being given out there? Fentanyl.
Yeah. Oh yeah.
Aren't you worried about getting people addicted to fentanyl because you're giving it?
Yes.
No, I'm not.
Why not?
We will never, because we will never, in the course of an EMS span, create an addiction. Now, we may feed an addiction. We may be abused because of an addiction, but you will never create an addiction on an ambulance. I'm sorry, just there's no way you will not have the patient long enough to create the addiction. It's not possible. Unless you're transporting to Canada and back, you will never transport a patient long enough to be the causative reason that a person has an addiction.
Well, tell me about fentanyl. This may be new to me. This may be new to other people. Why do we give it fentanyl? What's so good about it?
It has minimal effects on your vitals.
Oh, so it's contraindications. It's not any contraindications with fentanyl?
I mean, there are, but as far as like affecting vital signs, it's very minimal compared to other analgesic medications.
Good. Jason, you in there?
Yeah, I'm here.
All right. What about this fentanyl stuff?
I mean, everybody kind of summed it up. It's a great analgesic. It doesn't mess with your blood pressure. It's incredibly powerful. You know, we give it in micrograms instead of milligrams.
How long does
Sweet
it last?
spot on it is short duration, exactly.
That was where I was going. How long does it last? Short duration. Okay. Is it in our protocols?
Yeah.
Yep. Then why don't we give it more than 26% of the time in cardiac patients who are having chest pain?
There's usually the chest pain, if it's a true cardiac situation, it's not caused by pain. It's caused by ischemia of the heart.
Yeah, but pain increases myocardial oxygen demand, which
That's
will
true.
change the myocardial ischemia, making
Is
it
it
more.
is it decreasing it or is it masking it?
Well, if it's decreasing the pain level, it's decreasing the myocardial oxygen demand, so it would be decreasing the size of the infarction. Why would we want a patient to hurt?
I see what you're saying, Highland. You're right. The patient is still having the ischemia that they were having, even though you've given the fentanyl. That's a correct assumption, but the pain caused by that has a effect on the rest of the body, a reactionary effect, which causes an increased heart rate, an increased respiratory rate, thus an increased myocardial oxygen demand. That's why even if you're just masking the pain, you're actually decreasing the response to that pain, which should decrease your myocardial oxygen demand, or at least not allow it to increase.
And if you decrease the myocardial oxygen demand, you keep the size of the infarction the same as it is. If you don't take away that pain, you may increase the size of the infarction.
Oh.
Am I saying that right, Brian?
Sounds good to me. I just made all that up anyway.
I'm understanding it, so.
Oh my gosh, he's understanding it, Brian.
It's all
Okay,
coming
so
together.
Oh, wait, Tara's here.
All right, I have a question because, you know, I haven't been on the ambulance in forever. So I've never been on a call with fentanyl pushed. But in my mind, when you're going to give somebody fentanyl, okay, are you going to lose your ability to assess your patient correctly because they're not going to be able to answer clearly in a clear state of mind. So once you give fentanyl, is any information past that really going to be relevant?
Jason, I'm going to pass that to you.
I'm actually reading right now to find out if fentanyl is indicated in acute coronary syndromes, because there's some literature out there that says, and they may have corrected this by now, but the use of opiates isn't always indicated. So I was actually just reading, trying to find that information out, because I get what you guys are saying about pain, but I also understand that the reason we're treating that is to dilate the coronary arteries. And fentanyl does not do that. So let me read a second. Give me just a few minutes and let me see if I can get some more information on that.
We'll get back to you. Yeah. Does the use of fentanyl, those guys that have given it, does it actually wipe out the patient's ability to answer questions appropriately?
So as far as like altered mental status or cause them to change their mentation, I've not seen a whole lot of it. I've seen, yes, they'll get tired, sleepy, groggy, lethargic a little bit.
But they still answer the questions correctly, right?
Yeah, their mentation as far as appropriation doesn't change a whole lot. It's just their basically they get pretty tired. They get in that loopy kind of that comfort. I guess the big issue is, and I think they've changed it since I was learning, is that giving fentanyl or pain medication to abdominal pain, because it's hard to assess when you get to the ER. You know, you've masked that pain and they're not having that pain anymore, and the doctors can't do a thorough abdominal assessment because you have to palpate, you have to ask them questions. Hey, where's it hurting? Does it move anywhere? And they're like, no, it's not hurting now. And the accuracy of the physical exam decreases, so it's kind of harder to diagnose exactly what the issue is. But now
I would agree with. Go ahead. Sorry.
No, I think now it's treat all pain.
Well, and when I was a pup and we first got on a truck, the quickest way to be told you were an idiot was to ask for pain management for abdominal pain. I mean, they would have a fit if you asked for any type of pain management for abdominal pain. The nice thing about fentanyl is it's so short term that it can go away. If you've got any type of transport time at all, your patient will be back into pain soon enough by the time you get to the hospital. And I like you, would agree that answering Tara's question, I am sure you could snow somebody hard enough with things like fentanyl that you get some altered mental status, but generally I don't see that near as much as you did with
Morphine
and Versed or Demerol.
Yeah. Now, if you really want to talk about a pain agent that takes away the pain and it instantly clears up once they stop giving it, it's good old-fashioned nitrous oxide. What they do at the dentist office. They give you something, you breathe it, it makes you happy, it makes you laughable, and they go in there and they drill and break teeth and do all that stuff. And as soon as you take the mask off, it's gone, and you can go get in your car and drive. So, you know, we used to carry or were approved by the state of Arkansas to have nitrox on our trucks, and it was used for pain of fractures and things of that nature. And they were weighted masks. You give the patient the mask, they put it on their face. It was weighted so that when they got too much of it and passed out, it would fall off the face. The problem with nitrox is, well, you have to test it every day to make sure it works right. So the crews were coming in testing it, and the bottles were running out of nitrous oxide before they ever got to the patient. I'm not sure exactly why, but anyway, yeah. Commonly used agents: morphine, fentanyl, hydromorphone, ketamine, nitrous oxide, Nubane, and then your NSAIDs, Toradol and those sort of things. And these are all drugs that we can give out there. But remember,
I would offer something. Sorry, go ahead.
Go ahead. No, finish up there. That's good.
No, well, just in the interest of a conversation off to the side, have Z-Bay seen the green whistle, the Penthrox? P-E-N-T-H-R-O-X, Penthrox.
Penthrox?
Yeah, the first time I'd ever dealt with it, I seen it. I watched it on a TV show called Bonsai Beach. It's in Australia, and they call it the green whistle. And it's funny. It's an inhalatory analgesic, and they would do it for people that they have a bad, I think box jellyfish or something like that is their primary concern over there. And when somebody gets stung, it's evidently immensely painful. I've not dealt with that, so I don't know. But they give them this Penthrox, this green whistle, and they put it in their mouth, and they just take deep breaths. It's a snap together, pop it, and let them suck on it, and it creates it's a non-narcotic analgesic, but it works really well. And to me, it would be something that would be great for an ambulance, because you self-administer, they just pop it together and hand it to the person and say, breathe on this until you feel better.
Is that like nitrox?
Well, it's in its way. I mean, it's, I guess, it's not nitrous. It doesn't come in a bottle. It comes in a medication vial in like a nebulizer, but it self-nebulizes when you suck on it. It self-nebulizes. Look up green whistle if you ever get a chance.
Okay.
Really kind of a cool little aside. There you go.
There it is, right there.
There you go. Ta-da.
See, I thought you were crazy.
Well, I am. It has really nothing to do with nothing.
Stop opioids, green whistle.
Yeah, it's a non-narcotic. That's what's kind of cool about it.
I was looking for somebody that
Wait a minute. It says it's an opioid. An opioid.
Here you go. Wow.
That's the green whistle.
Well, it looks like a green whistle.
An opioid substitute.
Opioid substitute. Sorry. Well, we need to get that on truck, boys. We need to get some samples and try it and see if it works.
That's right. We'll have a green whistle party.
25 minutes or approximately an hour when administered intermittently. I mean, you can stretch this out for an hour. I need one of these before I go to the dentist.
Right. I don't know, but I watched them. They were giving it out like candy on that show, and that's what piqued my interest, was because these people would come in screaming and hollering from these box jellyfish stings, and then in a few minutes they were calmed down and basically back in their. They didn't make them goofy. I mean, they weren't drunk, they weren't crazy, they just were back down into a normal state of consciousness and out of pain. And I thought, wow, that's impressive. But I couldn't believe they were giving these lifeguards, and these lifeguards were giving it out like it was just, yeah, here, have some, yeah, here you go. And then when I looked it up and found it was non-narcotic, I thought, well, no wonder they're giving it out like candy.
Yeah.
It is potentially nephrotoxic.
Yep. Renal impairment, prior history to liver dysfunction following analgesic use, and susceptible and malignant hyperthermia. That would be awful, having hyperthermia. Anyway, I put that in the chat for you. Sorry. So that's a new one. The green whistle. I'll have to put that in my notes to remember that one. Thank you very much for sharing that one.
Sorry, I'm a master of side conversations. So.
No, that's good. That's good. You're like me. You're full of that useless knowledge that nobody else is interested in. What I'll have to write that down is because the next time I teach this, I will make sure I bring up the green whistle. All right. Okay, let's see. Jason, have you come up with something for us? Or Highland? How about y'all? They were off reading something somewhere. Tara, did we answer your question? Or we got you thoroughly confused?
Well, kind of both. I got an answer as far as it doesn't completely snow them under.
Right.
But my worry is with working in the ER, you never know your transport time because you never know what's going to happen on the way. Well, let me rephrase that. You know an approximate transport time, but you've got people like Jake that his body metabolizes most medications 2 to 3 times faster than normal. So I guess there's just a lot of variables. And like I said, I haven't been on the ambulance to where we've pushed fentanyl. So I haven't seen patients' reactions to it. I have in the ER, and I basically see them not answering any questions after you push it. So to me, it was, especially with a cardiac patient, is the pain getting any better? Or if you did have a trauma, is a contraindication of fentanyl certain types of trauma, because you've got to be able to assess mental status along the way to see if maybe car wreck or anything like that, there's further injuries than what was initially thought.
All right. I am only dealt with fentanyl a few times in my career, but Highland, you seem to have a pretty good handle on fentanyl. How long does it last?
So if we're going for pain management,
yes, sir.
Usually 15 to 20 minutes. Like she said, depending on metabolism, heart rate, all that fun stuff. 15 to 20 minutes is usually where you're going to get it. I've not had a lot of. Now I have had, let's say, your older female skin and bones. You'll give 50 to 100, and they'll get kind of, groggy and loopy, but they'll still be able to answer questions appropriately as far as that's concerned. But then you have your vent patients, and you use fentanyl to keep them, as far as pain management, to keep them from fighting the tube. I think vent patients, it lasts a little bit less than 15, 20 minutes in my experience. And I usually don't give, unless it's weight-based like pediatrics, I'm not going to usually ever give under 100 mics of fentanyl.
Okay.
Because if the pain is great enough to where I have to give fentanyl, I'm going to give you 100 mics of fentanyl. And I know our protocols say 50 to 100. But usually, unless they're skin and bones old lady, I may give them 50 to see how they react to it. Or if it's weight-based as far as pediatrics, if they're under 100 pounds, I think you have to calculate for that. So, and I believe it's, is it 1 microgram per kilogram, 2 micrograms per kilogram? Or is it 0.5? Is it 0.5 to 1 micrograms per kilogram?
For what?
For fentanyl, when you do a pediatric or anybody under 100 pounds.
Whatever the tape says.
Yeah.
Pediatric is 0.5 to 2 micrograms per kilogram from 1 to 12 years old.
Yeah. And like I said, I would caution if they're adults under 100 pounds, like some of these old or small women, I'd probably calculate, maybe weight based as well, because it's gonna hit them a little bit harder. But I was reading, and as far as cardiac ischemia, for pain, fentanyl and morphine were kind of equivalent. They only picked fentanyl as far as pain because it didn't mess with the blood pressure the way morphine did.
That's true, and respiratory drive.
Yeah. So as far as pain management and ischemic cardiac situations, fentanyl was proven to be a little bit more chosen.
Because it's 80 to 100 times more powerful.
Yeah. But like we said, also, it's not going to decrease preload. It's not going to decrease the cause of the ischemia, or it's going to mask the pain, morphine has that vasodilation just like nitro does. And that's going to hopefully decrease the issue as far as the cardiac event goes, and hopefully it'll decrease the pain. Fentanyl does not do that. But as far as pain management, fentanyl was chosen to be a little bit better than morphine.
Well, here are the side effects that can be serious. This is from Medline, by the way, Medline Plus. Changes in heartbeat, slows the heart rate down. Agitation, hallucinations have been seen. Fever, sweating, these are bad things. Nausea, vomiting, inability to get or keep an erection, irregular menstruation, decrease in sexual desire, seizures, hives, rash, and itching.
Is this for fentanyl?
This is for fentanyl. Yes, sir.
Okay.
I go back to the top so you can see it. Fentanyl.
Yeah. Oh, is that how you spell fentanyl? Man, I've been spelling it wrong for 5 years. I'm joking.
How should this medicine be used? This is my go-to. I go to Medline Plus. This is from the United States National Library of Medicine. So this is a good place to go. This is not Wikipedia. All right, don't ever go to Wikipedia. What should I do if I forget a dose? This is the oral medications they can. This is side effects. Cases of emergency overdose. What other information should I know? So there you go.
A brief lookup on that says that IV dosages usually will wear off between 0.5 and 1 hour is their duration. An IM is 1 to 2 hours. Not that we give any IM, but we could.
We could if we couldn't get that IV.
Don't.
Yeah. Yep. Don't give it if they take in St. John's wort. That's important.
Really? What's that? What happens? Do they blow up?
What special precautions? I don't know, but it says tell your doctor if you're on a herbal product such as St. John's wort. But it's interesting that it causes decrease in libidity. That was kind of interesting. Irregular menstruation, decreased sexual. I guess if you got somebody that's hooked on fentanyl, they don't need to propagate, have kids.
Any of that.
Yeah, any of that stuff. Here's the overdose symptoms. Keep all appointments. Yeah, there you go. Sure, it was helpful. I get off of here now. Let's go back. And back again. So, yep, fentanyl. These are the drugs we use. I hope we answered your question, Tara, because if you need to question the patient when they get to the hospital, if you're half an hour out, they should be coming out of this within a half an hour. And if you give it and you got a 20-minute transport, that's only going to be 10 minutes that they're going to have to get the questions to them. Document. Why is it important for us to document before and after pain medication giving or analgesic administration?
Yeah, to see if they've gotten better or worse.
There you go. That's part of it. Also, we need to document what's going on with them, so we're able to share that continuum of care into the next realm. Even though sometimes they don't listen to us, but we have that data there for them, and we can document it too. Want to know the level of consciousness, the heart rate, blood pressure, pulse oximetry, pulse rate, baseline. How you going to tell if they're hurting? If they're hurting, their heart rate's going to be what?
Technically increased.
Should be increased.
But I was kind of waiting on this. Be cautious when assessing pain using vital signs.
Yeah.
Because if they're on beta blockers.
Ooh. You mean the LOL?
You may not get accurate vital signs response to the pain.
No, a medication that masks a vital sign? That's what we're talking about. Analgesics. Okay, let's go on. Get a baseline, give your medications, and then follow it up after each interventions. Need to document what goes on because they're going to read about it. They may not listen to you when you go in, but somebody's going to read that chart. Follow your local substance policies for documentation, wastage, and storage. You know, can't say, well, I got 2 micrograms left over here. Nobody wants this, so I'll just take it with me. No, that ain't how you do it. You got your controlled substance logs, and we need to make sure that we're documenting everything on that and getting proper signatures, because do not want to get in trouble with that. Follow our quality improvement programs, uh, and follow our pain management protocols. And we have pain management protocols for adults and pediatrics in our protocol manuals. Get our benchmarks, track our plan, and then provide feedback to the emergency department staff, medical director, or patients. We got patients that have acute pain and patients that have chronic pain. So, what do we do about that? What do you think about this chronic pain stuff?
Well, people with chronic pain generally have a higher pain tolerance. So, minor pains, they might not even notice.
Very good. Very good.
So an issue that I've seen, and I'm going to give an example without giving up some HIPAA issues, but a gentleman we brought in the other night, pretty sure he was having some massive kidney stones, but he would take chronic pain medicine, gabapentin, Toradol, and morphine. And he ran out of his morphine that day. And then he called us and it said the pain was unbearable. And then when you get down to the meat and potatoes, he had some similar pain for about 2 weeks, but it wasn't as bad as it was now. And he was hollering, screaming, crying. And I'm sure if you're pushing a small pebble through your urethra, I would be too. And that's pretty much what it came down to, is his at-home pain management was covering up the actual pain of the kidney stone moving from the kidneys to the ureters and the bladder and now into your urethra. When it finally got there and he ran out of his pain meds, that's when he started feeling the pain. So.
So you're saying that his pain, he suffered through it as it went through the ureters, from the kidney down to the bladder, and then started complaining about pain from the bladder to the outside world, the urethra?
Yes, because he had ran out of his morphine.
So that should have been such much more intense pain than going down the urethra, that I'm surprised he made that.
Yeah, I'm telling you, though, if you could look at this guy and the substances that he was prescribed, he was probably using them and abusing them because he was I have an increased flank pain, I'm just going to take this and it's better now. And then it passed, I guess, within a few weeks, or it was passing. And this guy would not, oh man, he wouldn't take his hand off his penis, because I guess that made it feel better.
Sound like a
I
personal
wanted to make sure it didn't fall off.
Yeah.
Pain is individualized with each patient. There are some people that a little bit of pain, something that would cause me a great deal of pain, doesn't bother them. So, when patients report their pain level, it shouldn't be with our bias included. We should accept, if they feel it's a 10 out of 10, it's a 10 out of 10, even though it's a little bitty tiny scratch on their arm. If it's 10 out of 10 for them, that's what it is. And that sometimes gets in the way of our treatment. Chronic pain, they do live with it. They do manage it. They do feel like that at times they're able to tolerate bigger pain. But acute pain is one that we definitely need to work on, I think, a little bit more. There is a reference here to the American College of Emergency Physicians. We're going to look at that right quick, see if it loads. It did earlier. It's coming up right now. You got a gray screen of death, but it's coming. This is their policy statement for out-of-hospital use of analgesics. That's their paper on it. It's 2 pages. So let's see here. What do they say? Um, they believe that the advanced life support capable emergency medical service should provide analgesics and sedation. And this can be accomplished in a conjunction with close physician oversight and quality improvement programs reviewing both pain and sedative medications. Don't we do that right now with our RSI? That we actually do QI on those. And it comes up with basically 3 things that the EMS medical director should do. And it's uh, should consider the following out of hospital analgesics: nonsteroidal anti-inflammatories, acetaminophen have been well studied. That's one. And then ketamine, and then opioids is number 2, and then ketamine in low dosage is number 3. So why should we give it? Anxiety and agitation. Uh, most benzodiazepines are safe. Uh, and anyway, it goes on from there. Uh, Uses of benzodiazepines, multiple dosages, titrated dosages. Ketamine is listed there. And this was their 2015 paper. So that's what the docs, the emergency physicians, think about it. So there is medication out there we can use. They listed here fentanyl as the ideal narcotic agent. What do you think about that?
I can see it.
I can too. Jason, did you ever find what you were looking for about fentanyl in cardiac patients?
No, I I thought I had remembered something about um, something with the like using the platelet aggregators, that there was some studies or something about using morphine and fentanyl reduced the effectiveness of those like Brilinta,
Right.
because it inhibited that medication from being able to bust clots and stuff like that. But I couldn't find it, and maybe that was just a fleeting thought in my mind. I can't really remember, but um, yeah, the only thing I really found, I know back in probably mid like 2014, 2015, something like that, I think the AHA had come out with some statements about the use of morphine and fentanyl on patients that were having ST segment elevated MIs versus non-ST segment elevated MIs. And I couldn't find that information either, but I could have swore they had made a statement about that. And anterior versus inferior, I want to say there was some literature out there, but I couldn't find it. And I don't know if that's just me remembering incorrectly or just not been able to find the information. But I really thought there were some differences there on how we were supposed to treat those patients. Just like in an inferior, you're not given morphine, you're not given nitro.
Right.
So I don't know. I couldn't really find what I was looking for, but I thought there were some statements out there about that at one time.
Well, you keep looking, okay? And if you find it, please share it with us. You can put it in the chat, or you can put it whatever. But don't leave our discussion here.
Yeah.
Brian, you're ACLS guru that you are. What have you remember anything about the use of morphine or fentanyl in patients with taking clot busting drugs?
I have not. I haven't seen any of that, but they don't usually delve into that very much. Other than to tell you these are professional consults and you can do this and you can do that. I've not seen it. Doesn't mean it's not a fact. It just means I hadn't seen it.
I haven't either. And I call myself fairly well read. Brian shared some reporting stuff to me the other day, and Brian, I found that extremely enlightening. Reading some of those, it's kind of interesting. Some of their anecdotal um, things that you're going to be looking at in the future, and some of this stuff may actually be passed up the line, and medical directors may work on them. So it's kind of interesting. I like being on the cutting edge of stuff, so to speak. let's see. If fentanyl is is ideal narcotic agent, then midazolam is the optimal agent for anxiety and agitation. Comments on that? Is that true?
I'm from the older generation. We didn't have midazolam for a long time on the trucks way back then, but it sure does seem people sure seem to be fond of it, and the positive effects of it. I think you're gonna have to talk to people like Highland and Borg and those folks to tell you what this generation of people think about Versed. It seems to do well to me.
So I personally have not used Versed a whole lot. I've used it for intubation transports, and it works well on that. But as far as sedation for psychosis or something like that, I've not had success with it. And from what I was told, I didn't do it right. I was supposed to push it faster, and I didn't. And it didn't have the optimal effect I was looking for. But I have not used Versed a whole lot.
Is that the one that has the theme when you need to forget, remember Versed? Is that it?
I think that's ketamine.
Versed has that property as well. It's a hypnotic, but it's an amnesic as well.
Yeah, it is. That is the motto. I remember when they first gave it out there to us. They said, when you need to forget, remember Versed. If you want the patient not to remember what's fixing to happen to them, give them Versed.
I can see that. That's what they gave my son prior to his tonsillectomy.
Anytime I go to the dentist, then I need a shot of Versed. That's just because I don't want to remember it at all. Okay.
I kind of find that Ativan works better for someone that's just restless or is more anxiety driven. Now, if you're wanting to knock somebody out, I think Versed works better. But I think for just general anxiety, Ativan works much better for that.
Okay. Anything else on Versed? Sedative chemical restraints. Versed works good for those patients. Or what was the one you said, Jason?
Ativan.
Ativan. Mm-hmm.
Yeah, I mean, Ativan works better in just a pure anxiety type state. But if someone is agitated with anxiety, Versed works better because it really does knock out their drive to be agitated.
Okay, good.
You know, I'm curious. Devin, you're in nursing school right now. What are they teaching you about Versed? How are they teaching you?
We spent about 15 minutes on it, and that's about it.
Yep. Okay, cool. This is Versed. Move on.
This is Versed. Next. And they suggest ketamine here for violent patients.
Yeah.
Yeah, ketamine just flat puts you to sleep.
Not if you're ODing on bath salts. Yeah. If you're ODing on bath salts, it just makes you pee the bed, I guess. I don't know.
Well, yeah, if you're on bath salts, not a whole lot you can do. That's almost like LSD. That probably wouldn't affect those folks either.
They get massive doses of Versed if they're on that type of stuff.
Okay. So pain medication, combat anxiety, reduce pain, that improves the physical environment. If they are less anxious, if they are not hurting, they're going to be better patients. Okay. And here is that Wong chart that we were talking about. There you go. No hurt all the way up to it hurts worse. So the faces of Wong, I always thought that's kind of cute. But if you got this and you can clip this, snip it, print it, you should have it on a flip chart someplace. Just show it to the kid and go, which one of these most correlates to your pain? And here again, it's 1 to 10. So, I'm somewhere between here and here. Well, that's a 3. Somewhere between here and here, that's a 5. All right. And then there is the outer pain part, and that one's not found. I'm sorry. I shouldn't have clicked on that way. I apologize.
I bring this up just anecdotally. I wonder, they don't ever really do a comparison, the difference between pain and anxiety, and the treatment of pain versus the treatment of anxiety, which may be, anxiety is kind of mental pain, and the resolution of anxiety very well may resolute the pain because it may be manifested that way. But I don't think we touch on that hardly at all in pre-hospital healthcare. I mean, I'm sure they want us to not become psychologists and that sort of thing, but it seems like I've dealt with not to exaggerate, but it'll be a great exaggeration, 1 million people who probably could have used Ativan as much or more than they could have used fentanyl, Versed, morphine, or whatever analgesic I had. That they might have done much better in just relieving their anxiety versus relieving pain. I don't know how you guys feel about that. I mean, we carry Ativan now, but I don't feel like we use it significantly. And Ativan comes in some pretty usable forms, like sublingual and buccal, and I mean, some ways to give it. And I think it absorbs like in 20 or 30 seconds, so you could get some relief of these heavy anxiety patients, especially ones that you're going to start an IV on, or you're going to, I mean, some of these little, forgive my term, freakers, the ones that are freaking out on you on everything, and you'd like to knock them back down to the world of the humans. I guess thoughts or considerations on that? Anybody give any anti-anxiety medicine?
I agree with you. I think a lot of them, they're so hyped up with anxiety that it increases their pain threshold. It makes it seem true. When if we could just calm them down a little bit with some Ativan, I think it would probably lower their pain threshold too. I mean,
and you might need to give it for the patient and the parent.
Yeah, especially the parents sometimes.
Well, I'll give a little spray bottle and
maybe just atomize the whole room.
An Ativan grenade. What a great idea.
An
Chunk it in a room like a flashbang.
We just call it a pink whistle. Put it in a pink whistle, and then they can just use a pink whistle on it. Now, some of these kids aren't able to self-report, and then we can use the FLACC scale, the FLACC. Have you ever heard this scale before?
No.
Means faces, legs, activity, cry, and consolability. I clicked on the link here, and the link is no longer any good, but it's the FLACC scale. It's for non-self-reporting pain, and basically it is your ability to read the patient. How is their face looking? How do their legs, and how much activity do they have? The kids' work is play. If you come in and a kid is not playing, then that activity score would be low. Cry and consolability. If they're crying and mama can't console them, daddy can't console them, nobody can console them. They giving them a bottle won't console them. That's pretty painful if they can't do that. But the history and physical exam is big for this FLACC scale. Jason, have you heard of this thing?
Yeah, we use it in the ER quite a bit on kids. It's a 0 to 2 per criteria. So if they're acting appropriate, they get a 2. If they're not, they get a 1 or a 0. And so it's for us to determine how much pain they're in, because they can't tell you how much pain they're in.
Right. They can't report it.
Right.
I was fixing to look, see if I could find it somewhere else.
Yeah, I think I can't remember how many criteria there are. There might be like 5 different criteria, and then you're grading them on a 0 to 2 scale for each criteria. And I think the total comes up to 10, if I'm not mistaken.
All right. You're right. 0 to 10.
I will say a little bit on the Versed Ativan argument, or not argument, but discussion. We don't ever give Versed in the ER for agitated patients. They always get Ativan. So the use of Versed in the ER is actually pretty limited. We actually hardly ever give Versed. And I don't know if that's just physician choice at our facility. I mean, when I was flying, we gave Versed like it was candy. And we carried Ativan and Versed, but Versed was the most commonly used. So I don't know if that's just a physician choice in the ER there, but we very seldom ever give Versed for anything. They use every other drug but Versed. So what I found is the Ativan really does work well in just a pure anxiety type patient. So now if they've got other things going on, obviously it's not going to work as well, but I don't know, just my 2 cents on that discussion.
Good points. Good points.
Hey,
Here's
Casey.
the FLAC scale. Can y'all see that?
Yeah. Hey, Casey, Matt's trying to get back in.
Matt's trying to get back in. Well, let me go
Yes,
see. I didn't see him here. Oh, there he is. That's good. Now he's back in. Here's that FLAC scale. Face, legs, activity, and here's the cry, and here's the consolability.
Hey, Casey, I'm back in.
Thank
I'm going
you,
to be
Matt.
driving for a minute.
Okay. I'm going to blow this up where I can see it. If it will come up. All right. But that's the FLAC scale. And as he said, it's either a 0, a 1, or a 2. 10 is the best, 0 is the worst. So, yeah. Going on with pain management here, there's, multidisciplinary complementary methods here. We can use distraction. If you can get the kid watching a lot of times they'll do something in the room, put in a what is that called, a fidget spinner thing. If you can distract them with something like that, that will take care of them. Sometimes it could be a balloon. Sometimes I have a friend that does magic. He does magic, and that distracts people from pain. They're talking about alternate procedures here. Steri-strips versus sutures. If you put in a Steri-strip, they're not going to get near as crazy as if they get sutures. Steri-strips usually just draw the skin, approximate the edges close together. It's just tape. Whereas sutures, you have to give analgesia. You got to give, the xylocaine. You give it in there and you deaden it, then you sew it up. Kids don't like that stuff. Kids don't like being tied down, roped into. So there you go. And it's talking about how we give it. If we're giving a local anesthesia, you're giving it with a 25 gauge needle, and you're giving it just into the epidural space there. Not epidural, epidermal space. You make it a little wheel, and that takes care of that. Then there's oral medications. What about the use of, what is it, fentanyl suckers? Don't they have suckers they give kids like that?
Hey,
Tara?
Casey,
Yes.
Jake wants to know if you'll let him back in the class.
No, he's voted off the island. All right.
I don't know about fentanyl suckers, but I have teased about trying to make Versed suckers and everything else so people will just go to sleep and leave me alone. Ativan suckers.
Okay.
I've seen those fentanyl suckers used in the ER.
You have seen them in the ER?
Of course, that was in a southern part of the nation.
Okay. Did it work?
Oh my goodness! Used it on my daughter. She got bit by a dog, and they had to sew her up. Gave her a fentanyl lollipop. She loved it.
She loved it. Was it the lollipop distraction, or was it the medication in the lollipop?
And a lollipop.
Yeah. Okay. All right. Oh, by the way, breaking news in case you wanted to know, Facebook has permanently banned Donald J. Trump from Facebook.
Censorship.
Oh, well, it is what it is. Let's see. The end of all of this is you need to follow pediatric pain standards. Need to follow what the ACEP says. We need to be aware that medications use in children less than 6 months. Analgesics does get there to the liver and hang out, and there is metabolisms may take up to 6 months for them to break down. That's always interesting. Topical anesthesia requires appropriate dosing, and there is no prolonged exposure to that. So, yeah, research. It says here we need to consider conducting research for evaluating pain management in local areas. Intranasal versus intravenous. I know I had rather have it up my nose than stuck in my vein. Um, is fentanyl one of those drugs that can go intranasally?
Yes.
Ketamine and Toradol? Yes, they can. They can. And we already said that fentanyl works in a sucker, so if it'll work in a sucker, it'll work straight up somebody's nose. Comments? We've been at this an hour. That's exactly where we're supposed to be. So we go back to the big question that we looked at a while ago. That ain't the big question. Where we were looking at the use of analgesics in chest pain patients is still 26%. That's considerably low, correct? Do you think that's low? What do y'all think?
Extremely.
I think it's low. How about you, David? Is it low? 26%
Thanks,
for
my glasses
cardiac
on.
patient?
It seems pretty low to me.
Yeah.
I thought it would have been higher.
Ooh.
I think especially if we look at probably our transport times are, I don't know, I'm saying this off the cuff and I don't have, this isn't necessarily factual, but I figure we're transporting at least a high percentage of these on up to Branson. Now, are we differentiating these from e-calls to transfers?
Yes, we were.
Okay.
That's
So
20% of e-calls. 26% of e-calls.
My point to that being is that the people that we feel like that are in some serious pain, we are taking up to Branson. We're running them 30 minutes out of town. Granted, it's only 30 minutes up there, but you would think in that 30 minutes, unless you're busting hump to try to get a bunch of other things done, that you would have time to give some analgesic.
You'd think. And isn't it all about patient comfort? Isn't that what we're about? We wanted to make our patients seem to do better. Am I missing the mark? Justin?
Well, I guess some people would argue that it's all about patient care, but then care and comfort do go hand in hand together.
I agree with that.
Thank you, Matt. Jake, what do you think about that?
I got the last half of the question. Are we talking about giving cardiac patients pain protocol?
Yeah, or any patient pain medicines.
I think there's a gray area where we need to be treating these patients appropriately. With that, we need to be good stewards of our pain medication, because if someone's truly hurting, you know, they may say their pain is 10 out of 10, and you may look at it and be like, you know, okay, you're full of crap. That's a 3, but it may be their 10 out of 10, because that may be the most that patient has ever experienced. And in cases like that, you know, yes, we need to treat, but I think we also have to be vigilant in differentiating between the true pain patients and the ones that are playing the system, knowing the right wordage in order to get the pain medicines they're seeking, i.e. patient that I transport multiple times out of Searcy County that always complains of chest pain, and she's never a cardiac patient. Now, not to say that she won't be the next time I go, but she knows the right words to say, and the strange thing is she wants nitro. That's what she's begging for. But you know, I know that patient because of a personal history with her. So patients like that, we need to be careful. We don't need to treat just because they're wanting the medication, because we don't want to add to that, you know, epidemic going on right now was, you know, our opioid crisis. However, we need to be treating patients appropriately.
And you probably weren't here when we went through that part. And the National Registry said that we did not need to put our own bias on patients. So we need to be real cautious of that too.
Right.
Okay, good. Thank you. David, did you want to say something?
No, I'm just kind of surprised that you're asking. That's just caught me as unusual.
What caught you as unusual? What?
Well, he's a regular patient. He was talking about, and she wants the nitro. I was like, really?
Yeah, I didn't know nitro was a.
Yeah, for morphine or fentanyl.
Yeah, if it's going to be me, I'm wanting some of the good stuff.
Mm-hmm.
If it ain't got a C on it and a little number in it, I don't want it. That's the only thing that helps me. All right, Devin, you still here?
Yes, I am.
Good deal. You have anything to say about the analgesics these paramedics are talking about?
I mean, I agree with everything. They both go hand in hand with each other. I think it's important for pain management, because who are we to say they're in pain or not, you know?
True. Todd?
Yes, sir.
Yes, sir. Pain medication. And you may say, I can't give pain medications. I'm just an EMT.
You're right, I can't, but I could say if I'm the patient in there and I'm hurting, please give it to me.
Yeah, and if you're going to intubate me, you better knock me out, because I'll hurt you. All
That's
right,
right.
let's see. Jason, we've heard from you lately. Highland, are you still around? You want to talk about any of this before we move on to something else?
Well, no.
Okay.
So I think when I became a medic, I was in that phase where I was trying to be really cautious about giving pain management. One, because it was new to me as far as giving to patients, and I was a little gun shy. But two, because, you know, I was skeptical of the patients. So do they really need it, or do they not, or is it necessary? But at this point in time and juncture, if you have if it's not chronic, if it is chronic, I may treat appropriately as far as trying to reduce the pain. But if it's a chronic pain and it's not acute, I mean, that's a little bit different. But now I pretty much treat pretty much any pain with pain medications if I feel it's necessary. I mean,
but that's when I think we can also maybe we start lower doses, obviously, but maybe we can give a little lower dose, and then they're going to get that double effect from it. They're going to know we're giving them something, which is going to help probably calm them down a little bit, and they're also going to be getting some pain medicine, so that's going to also help them. So maybe starting smaller and then working your way up, instead of sitting there saying, okay, well, chronic back pain, okay, well, here's 100 of fentanyl. You start like, well, here's 25, and kind of see how they know you're giving them something, and you are. So you're going to get like a double effect out of it too.
I remember early in my career when I was decided to give morphine, I would let them know this is powerful stuff that we're giving here, and you know, we don't want to give you too much of it. So you give that psychological effect to that, and that that's a lot of it, right, Brian?
I'd agree. I think that uh, there's a lot of difference between those of us who've been in it 30 years who had to call and ask for, could I give 4 milligrams of morphine to this patient? You wouldn't dare. I mean, initially, you wouldn't have dared just whipped out some pain medicine and gave it to somebody because you thought they were in pain. And then I remember when I thought I was quite the shit because I didn't have to ask anymore. They had enough faith in me and my skills that I could get away without asking for pain meds. I could give what I wanted, but I was extremely cautious and probably withholding more than was ever warranted to withhold. And I think it's taken a long time to breed that out of people. I think getting people to feel a little more comfortable with giving those pain meds has been a long time in coming. Obviously, we don't want to be idiots with it, and we want to be good stewards of the medication. But I think one thing that's happened, unfortunately, has fallen to the side is we forgot there's a whole crap load of things that you can do to resolve pain that don't go through an IV and don't require a pill bottle or a prescription, and positioning, cold, hot, stabilization. There's a lot of things to do.
Ice, compress, elevate. Yeah.
Well, and not putting them on the spine board. How many people? I mean, I just harken back to my career. I know I made people absolutely ungodly miserable,
crazy,
strapping them down to the spine board hard and tight, because by God, that's what we had to do. They had to be secured and they couldn't move. And so to me, heck, just the fact that we've gone away from some stupidity has been some pain treatment in the grand scheme of things.
True. And sometimes just talking to them, a little distraction by talking to them, asking them what was, asking them a little bit about themselves, especially the elderly patients. They'll respond to that. Kids, not so much, but you got an out with kids because you can say, well, you go to school, what's your school, who's your teacher, and all of that is a distraction away from pain. If they focus in on that pain all the time, that's what they're going to feel.
It's always good to ask them if they come here often.
You betcha.
But you probably already know the answer to that.
Okay. Who was that? Go ahead.
I was saying, someone made the comment about, reducing your dose down to smaller doses to see if you have any pain relief with it. Now, don't take me out and stone me in the backyard here, but this is coming from years of management with Cox EMS. When you reduce your dosage down, you may have to give a second or a third dose, to get pain control. But at the end of the day, that second dose of that medication allows you to bill for an ALS2 run, and those patients are going to get, their surveys, and your pain management is going to be reflecting in those HCAP scores, being a hospital-based service. So ultimately, you can treat your patients, take care of their pain, get better scores, increase your HCAP for the hospital, and you can increase revenue by being, more dosages and being able to bill for ALS2 on those rounds versus ALS1.
That's factual.
Spoken like a true administrator there. That's good. And true also, because if you give them second shot, they're going to go, wow, I guess that must mean this is good stuff and I got a second shot, and that'll help. All right, good deal. Y'all ready to go on? Let's move on to the next topic, which is going to be the psychiatric. Yeah. Can y'all see that okay? This is we're going to talk about mental status examinations. We're going to talk about effective patient restraint, verbal and physical. We're going to talk about some risk factors for suicide. We're going to talk about opioids and excited delirium. We're also going to talk about some synthetic stimulants. That's your bath salts, natural and synthetic THCs. And we're going to talk about those. All right. So let's kind of get started. So, altered mental status. When you talk about altered mental status, in the realm of EMS, it's like talking about a domestic disturbance to law enforcement. Domestic disturbance to law enforcement means anything and everything is possible. If we're going for a mental, uh, altered mental status patient, in EMS, same thing applies. It can be anything and everything. Um, so, what are some things that can cause altered mental status or altered behavioral status?
Glucose.
Yeah, diabetics, hypoglycemia. Let my blood sugar get low, and I will get a little altered mental status going on.
It almost goes back to H's and T's, honestly.
Yep,
Mhm.
very good, very good. Head injuries, hypoxia, write down H's and T's. Stroke is not an H's and T's. I guess it'd be a thrombosis, coronary, not coronary, but cerebral. And then dementia. There are dementia patients we deal with. And then there also can be those people that are on medications. Too much of one thing, overdose, abusive, those sort of things. Now, mental health histories, you're going to be able to pick up on that, maybe because you've seen them at the meetings, or maybe you've transported them many times, or you go to they're going to have a caregiver that'll give you this information about mental health history. Sometimes you just look at their general appearance. How do they look? I mean, we can look there at David in the truck. There he is, back with us. Very nice dressed uniform, all happy, smiling. He's well groomed. He looks like a well nourished, well developed person, right? And then you look at my dress. Well, I'm dressed in a t shirt. I got a beard. I haven't been shaving. My posture, I'm leaning back. I might wring my hands. I might be grimacing. I might have hyper startlability. I might be startled easily. My mannerisms might not just be exactly right. And I may be lashing out. And if you get that stuff, that may point to this all mental status and let you kind of go, well, they're not all together where they should be. Not everybody can look like somebody that's homeless and still have an altered mental status. Just because they're homeless doesn't mean their mental status is off. So listen to the way they talk. Listen to the way the staccato of their voice. Are they loud? Are they soft? Are they understandable? Can you follow what they say? Do they make sense? Is it I love the word thing here. They call it a word salad. Are they just saying words to say words? Or are they phonetically putting together complex sentences? Are they delusional? Are they talking about helicopters eating their babies? Tara, did you have something you need to say? Want to say?
Jake and I have encountered, especially more so with the older population, um, being delusional, and it's caused from a UTI.
Yeah, yeah. Toxins can get in there and can cause that. Sure thing. Thank you. Good point. Good point. Um, what's their mood? That I picked up a fella who had run his truck, full size Chevrolet truck, into a bridge abutment, and he was sitting on the tailgate singing Blue Jean, Baby Queen, Rock On. He was not depressed. He was kind of leading on euphoric, and it made me wonder if he had encountered a head injury from his crash. But they can have mood swings. They can be manic. They can be anxious. They can be angry, agitated, fearful, guiltful. They go through all of these, and they can go through this range of emotions in just seconds. They can be fine one minute and they can be yelling at you the next. And we have to be careful with them because, altered mental status patients, could be a chemical imbalance. It can be, you know, actual behavioral situations. And we got to watch for these people, because they can be uh, violent. Um, Look how their thoughts, are their thoughts racing? Are their thoughts constructive and in a single line? Do they have all their ducks in a row, so to speak, Highland? Or are they just shotgunning, just blasting off and here and there and here and there and everywhere? Do they have hallucinations? Are they hearing things? Do they have visual disturbances? Or, did you touch me? I'm having pain and I don't know what, something's sticking me, and there's nothing sticking them. This may be a hallucination. They may be hearing colors and seeing sounds. Definitely a problem when you get into that. They may be obsessive compulsive. They may be delusional. They may be suicidal. And be careful of those that are suicidal, because sometimes the suicidal patients are also homicidal. You know, delusional. They may have false beliefs, and they may be totally disconnected, as in patients that have dementia. They're not connected. They don't understand where they're at, why they are, what's going on, and they may be disturbed or distorted. Now, once you get your mental status evaluation done, you should always look at their general appearance, their speech, their mood, and area of thought. You know, why is this patient acting the way they're acting? And sometimes it can be as simple as, you know, somebody is there and they don't want that person there. And the best way to calm them down is to what? Simply remove that person from the scene. Ask them to go to another room. Move, separate the parties, if you will. Uh, uh, Gosh, dealt with some really strange patients, and some of them, you know, I walked into one room one day with a lady that was a mental patient. She looked at me and she said, "Uncle Bob, it's so glad to see could be here. Come on over and let's talk." And we sat down and we started talking, and I didn't know her from Adam. And apparently she related her Uncle Bob to me, and we started a conversation about Uncle Bob. And she went on and on and on, and she calmed down. She was actually attacking the deputy sheriffs that were there, and when I came into the room, it was just old home week. And we didn't have to do any physical restraint on her. We just got her working, and got her going, and talked to her. Just let her believe I was Uncle Bob for a little bit, because it didn't hurt anything. And we walked her right to the truck, took her on to the hospital. And about the time we got to the hospital, she looked at me and she shook her finger and she said, "You're not Uncle Bob." And I said, "No, I'm not. I'm Casey. I'm a paramedic. We're getting you some help." She said, "I appreciate that. Well, I surely thought you were my Uncle Bob." And she thought that. So we didn't have to restrain her. Before that, we were getting ready to, uh, I don't know if any of y'all have ever done any of that therapeutic restraint for therapeutic reasons. But yeah, we were fixing to get ready to throw down and get after this lady. Takes about 6 people, 5 or 6 people, to actually restrain somebody physically, and you got to do it in a safe way. Um, can't kneel on their neck. Going back to Mr. Floyd, we can't do a lot of things, and we've got to be watching for this excitability delirium, excitable delirium that we're going to talk about later on here. But we can tie these people down, and they can actually go into cardiac arrest just from being restrained. And we have to be careful about that. We got to ensure scene safety. There was an ambulance in eastern Arkansas transporting a psychiatric patient. She got out of her straps and jumped out of the back of the ambulance at 70 miles an hour and was hit by a car behind the ambulance. You know, that is negligence on their part. You've got to keep your patient under control. You've got to make sure they can't get up and get out and hurt themselves. You don't want them to hurt themselves, and you definitely don't want them to hurt others, because I'm back there. I don't want to get hurt. Um, there are pharmacological restraints that we can use. Uh, and, if you get on the scene and they got a weapon, the scene's not safe. And probably we don't need to be on the scene if they've got a weapon. And I'll leave that up to your own discretion whether or not you leave or not. But mostly, you need to keep yourself safe because we've invested a lot of money and training into you, and we want to keep using that as long as we can. Go ahead, Highland. You got something?
No, sir.
You had any psychiatric patients, Highland, that you've had
Oh
to
yeah.
talk down?
Yeah,
Oh
he
yeah.
doesn't have patience for him.
That's why you're there, Devin. Devin is usually the psychiatric favorite when we're on scene.
They like you, Devin?
They do.
Yeah.
You're their
Sometimes
Uncle
a
Bob.
little too much.
He's got blue eyes.
You're their Uncle Bob, right?
Yeah.
I'm their Uncle Bob or the Antichrist, whichever one you want to call me.
Whichever one they prefer.
Okay.
That's what they called me. We had a
Antichrist?
patient. This patient 2-3 days ago called me the Antichrist.
Ah,
But in a good way.
But in a good way. I don't know how that makes sense, but yeah.
I don't either, Devin, but okay. Yeah. I'm not taking your mark, by the way, Devin, just let you know. Okay, let's go on here. How about some of the rest of you that's out there? Share some on your, there's 10 of you out there. Surely Jake or Jason or Matt can give us some idea on psychiatric patients and restraint of patients like that.
I had hundreds of them over my years in Springfield, if not thousands. A lot of them drug induced. Gave a lot of vitamin K up there.
And how did that work?
Normally pretty well. I had one 110-pound girl that I swear was possessed by Satan himself. I mean, was throwing 400 pounds of EMS provider around like it was nothing.
Refer that back to Devin. He's the Antichrist, so he knows about those.
Yeah. But a second round of ketamine, took care of her for the most part. But
Okay.
Ultimately, I mean, ketamine is a go-all drug. Be it cardiac, burns, psych. It's my favorite.
It will calm them down, won't it?
And it's not hemodynamically effective too much. So
okay. Matt, talk to me about chemical restraints.
I'm sorry, talking about what was that?
Chemical restraints.
Oh, chemical restraints.
Psychiatric chemical restraints.
Sure. I've never had to chemically restrain anybody that I've known. Besides, well, I say that it's like mildly. They sometimes get just like a milligram of Ativan, and sometimes that works for them. But I've heard people have to give ketamine for someone with excited delirium and going all kinds of stuff. They're just extremely combative. But for me, I've never had to go too much past when we had Valium or okay, 1 second, sir. Ativan and so that's that's usually just if I can't talk them down and they allow me to do things to them. If not, I just kind of leave them alone. If that works, if it doesn't work, that's what I shoot for.
Okay, good deal. Thank you. So restrain only those that we can overpower with physical forces. If they are demon possessed, then 400-pound person is not going to be able to hold them down. And use the force only necessary to restrain them from preventing them from injuring themselves or others. Takes 5 people to fully do it. There's a course out there called Non-Physical Crisis Intervention. It's a great course. If you hear of it, take it. It'll teach you how to control people that want to hurt you and want to hurt others. You need to pre-plan each person's role when you're getting into restraining somebody like that. You don't want to just go in there and everybody grab, because if you everybody grab something, everybody's going to grab the right arm, and that way their left arm is free, or they'll grab the left arm and the right arm's free.
Now,
So
at the state supported living center that I used to work at, that was our like yearly refresher thing that we would do, was going over how to talk people down and how to physically restrain them and who directed what roles. And so I understand that a little bit too.
yeah. Did y'all do the non-physical crisis intervention, Matt?
Man, I don't know if that's exactly what it was. It's been a decade or more since I've done anything with them, but I don't remember exactly what it was called. I just know we had the instructors who would come in that would teach us all the correct techniques,
right,
and how to.
Was it DT for EMS?
DT for EMS is a good one too. The one I'm talking about is called non-physical crisis intervention. It's taught by the CPI Institute. I went to it, and they teach a lot of behavioral facilities how to get out of it, how to get out of holes and things of that nature. And basically, when you're getting these people, you give them a yes answer. You only ask them a question. It's either yes or yes, and you try to enforce it. You don't give them things that are outlandish that they don't understand. If you don't do this, then I'm going to take your television privileges for a month. You can't do that, so they know that. So yeah, got to be swift coordination. Talk to the patient continually, and once you get them restrained, don't take them out of the restraint until you get them back to the hospital. Why is that? Why would you restrain them and then not let them up until you get them back to the hospital, even after they calm down?
One, they can just go revert back to where they just were. Who knows how fast?
True.
And for two, if you had to go to that extent of doing that, it's good just to keep them and yourself safe until you either A, get more help, or B, get to a place that can take over.
Going
Don't
back
want
and
to get
talk.
butt kicked by a 93-year-old woman. That's why you keep them restrained.
There you go. Don't get kicked by a 93-year-old woman. And don't let them jump out of the back of the ambulance.
Then don't let them do something in the ambulance.
Yeah, that's very true. Thanks, Dave, for sharing. Let's see. Thoroughly document your restraints. If you do a restraint, tell why you restrain them. And they need to be, restraint for therapeutic reasons is not a good answer. You need to explain why. Sometimes if they're in law enforcement custody, that's a different type of restraint. They'll be cuffed in those cases. Yeah, follow your guidelines, your protocols. What do you do about a patient that's handcuffed? Does the deputy come, or the law enforcement officer come with them in the back of the ambulance if they're in custody? Age, what age do you do that? What is some different ways of doing age? Restraint should not hurt the patient. That's the key thing. You should not have them restrained and hurt them. Ensure continued ability to restrain, because you don't want them jumping up and running off, or running up front and jumping on the driver. That would never be good. And you need to have adequate personnel. Tara?
I know one of the things that's not talked about a whole lot is, depending on how long your patient is restrained, is before your patient is restrained, or actually right after, making sure S&Cs are intact, and depending on how long, and if it's more than 30 minutes to an hour, rechecking and documenting that you rechecked at such amount of time that S&Cs are still intact, that they still have pulses and everything.
That's right.
In those extremities.
These restraints can cut off circulation to these extremities, and we want soft restraints, right? I mean, let's use the restraints we've got. I'm sure we have some on the truck. I know in other services I've worked, we've had soft restraints where we can put them on there, and also we've got straps and things of that nature that we can use. We want to make sure that we always restrain them in a way that we can clear their airway in case they happen to vomit. Um, we got to understand the normal range of motion. We got to know which way is weaker. There is weaker points at the thumbs. There's weaker points coming up. than down. So we need to understand muscle groups and range of motion. And that's some of the things that CPI class, and Matt, even your class probably talked about why you restrain down and not up and those sort of things to understand some of this muscle grouping.
No, this doesn't even have to be for psych patients either. I mean, even if we have somebody like sedated and intubated, like on the vent, and we have to keep their extremities out of the way and keep them protected. So if we use some kind of restraint on them, like
True.
She said earlier, that's what I was going to say too. But I mean, always recheck your SMCs for even those sedated patients.
Absolutely. Now, what about different patients that we may have? You may have a pregnant patient that needs to be restrained. Is there any problems that can happen with pregnant patients?
I mean, you got to keep them on their left side if they're, so many months.
Yeah, if they're in that final trimester, you can cause a great deal of hypotension by just laying them on their back. So left side is the way you need to put them. Right. Very true. How about pediatric patients? Any problem with them? Has to do with their airway.
Pediatric patients have a fatter neck. They're more likely to compromise their airway.
So we need to make sure that we have a pillow or something underneath their shoulders so we put their head in a sniffing position. Good. And then geriatric patients. What about restraining usins that are old, like Brian and myself?
I would think something along the lines of people that have maybe like arthritis and their bodies are contorted a little bit differently just because of life. And so keep them comfortable, make sure that they maintain their airway also, and don't move anything that's not in a regular position for them. Instead of like, okay, this is standard, but maybe they have a little curvature of the spine or arthritis in the joints and don't want to hyperextend anything that can cause constant pain on them.
And Matt, very true. If they've got that that scoliosis of the back, where they got that hunchback, that lordosis in their back, if you try to flatten those people out, it ain't good. And some of these geriatric patients, you can put them on their back and their head will just bob there because they don't have a pillow underneath their head. And if you try to flatten that out, that's going to definitely cause problems too. Okay.
They have thinner skin. You're more likely to have skin tears.
Oh yeah.
Because they have lesser fat deposits under their skin.
Right.
They also have less bone density, so it's more likely for them to break or fracture something.
Very good, Tara. Good job. All right, Todd, anything from down south around Jasper?
We don't have any psychiatric patients in this area that have to be restrained, so we are in good shape in Newton County.
All right, good. I'm glad to hear that. I hope you never have to restrain one of your students either.
No, we've been there. We've had to do that before, but I'll save you the stories.
Okay. Then they're talking about environmental restraint here. And that's some of that I was talking about. You can calm the patient with therapeutic communications, and if you separate that stimulus from the environment to people, sometimes just having law enforcement out of the sight, that'll calm them down a lot of times, especially if they've been tased and they're coming up. They can get a little bit aggravated there. That sounds like an alarm.
I think that's good for adolescents too, like that don't want to talk to their parents or in front of their parents about things. We had one just last week about that.
All right. True. And here again, and that's just environmental. We had I had a lady, and I was not going to tell you the story, but we got her in the backyard, and she was holding a butcher knife at her belly, and her story was, by the way, now she's standing in her backyard with a halter top and Daisy Duke shorts on. She has aluminum foil wrapped around her head. Y'all, I'm trying to get y'all to picture this. And she's standing there with the knife, butcher knife, an old hickory butcher knife, holding it just above her belly and a belly button. And she said, "My belly button is talking to me." And I said, "Well, wait, we actually talked her down, and I got her talking to me instead of her belly button." And she was out there, and finally got her to talk down enough that she took the knife and stuck it in the ground, and then come and let me in the back fence, and we got her to the hospital. But she was out yonder. But she did not want to talk to the law enforcement. These cell phone towers were beaming things into her house, and that's why she had the aluminum foil around her head. And they had beamed in enough stuff now that her belly button was talking to her. This was obvious a psychiatric patient. And just by getting the back law enforcement to back off a little bit, letting staying out of her range with that butcher knife and getting her to stick it in the ground, and then getting to talk to me and then come around, it all worked out as we kind of separated the stimuluses that we had out there. And we told her that once we got her in the ambulance, which was I told her a little lie, that the ambulance was lead lined and they couldn't beam those things from the cell phone towers into our truck, that she put down the knife and come with me. So yeah, well, the things we do sometimes for the good of our patients. But then there are times that talking them down, environmental restraint is not going to work. We got to have to use chemical restraints. They got a threat to themselves or others, and we don't have enough people there, and we can actually get an IV started on them. Then maybe we need to think about chemical restraints. And Jake said it with vitamin K, ketamine. We've also got the benzodiazepines that we can use, and some of the antipsychotics that may be in our list. And we need to titrate that to the level of agitation. We need to try to combine therapies where we can. And talk to medical control is always a good part. And please follow your local guidelines that's out there. Uh, we got routes of medication: IM, IVIO, nasal, and even buccal PO. So, all right, questions on talking about restraint techniques. We don't have to tie them all down, but we got that capability. But we do need to restrain them if they are hurting others or hurting themselves. We can't let that go on, and we got to take care of them. Questions, comments? Round the room. There's 10 of you here now, 9 counting me. So let's hear what you got to say. Brian?
Well, it's as simple as this. If you ever thought you were responsible for a patient before, if you decide to restrain them, whether that be chemical or physical, you are 100,000% responsible for them. You cannot be more responsible for somebody than after the moment you restrain them. And I mean, that means for every portion of their well-being. Psychological, physical, earthquakes, hurricane, whatever.
Airway, breathing, and circulation has to be maintained.
Ask a local hospital. I mean, one within 74 miles of us. What happens if you don't pay attention to somebody and something bad happens?
Ooh. They were restrained and something bad happened to the patient?
Yes.
Yeah, I was up there for that. That was crazy.
Just okay.
You're right. Really, really, not to belittle the fact that somebody could lose their life and or other things, but you're right. Really, really, really big checks that at that moment.
Yeah. So it's probably more heavily weighted on our minds as EMS professionals than giving analgesic medications. I know I never did like to restrain patients, and I'm not making light of it. Talking them down, I prefer the environmental way of restraint, removing them, remove the stimulation, You know, if it's a family member there agitating them, you know, getting them out. Um, yeah, several times that's worked. But now there has been times that I have had to go, you know, full bore, 5 people. Let's you grab an arm, I'm getting an arm, you get a leg, you get a leg. I'm gonna protect the head, and we taken them down that way, and then assisted with putting them into soft restraints and putting them on a stretcher. Never sandwich them between a spine board. That's never a good way to go. Never allow law enforcement. Uh, never agree with law enforcement that hog tying is best. Uh, Kneeling on the neck is not a good thing. All right. Yeah, are y'all with me? Where else here? Let's see.
Yep, we're here.
Okay. Matt,
Haven't done the hog tying in about the last 12 to 15 years. That's old.
hey, I'm old. What do you think?
Well, that's been taught to us when I went through the academy in 1997.
Yep,
We don't do that anymore
that's good. That's good.
because they had so many in custody deaths because of the positional asphyxiation. So they stopped that a long time ago.
Don't be part of it if it's what I'm saying here. All
Be a
right.
patient advocate if you see it too.
Oh,
I
there you
think.
go. I concur. All right, I'm gonna get this out there on y'all's chat if I can do it. There we go. I said I was. Where did the chat button go? Huh. It's doing weird things again. There it is. This is a link to the uh, National Institute for Medicine. Excited delirium. Excited delirium. I think in a lot of cases, and David, this may be a question for you. This is something that excited delirium disorder may be one of the reasons a lot of people in custody uh, go into cardiac arrest and die.
Yes, I've seen it actually.
Well, you know, in jails they put patients, they put inmates that are acting up in a chair and strap them in that chair, and then these people go into cardiac arrest. Um,
Yeah,
Go ahead.
phenomenon, especially if they got any kind of drugs on board, particularly cocaine's or some kind of, you know, stimulants like that. They fight to the points where they exhaust themselves and then they go into respiratory arrest. We had one that happened with me actually.
Okay. This is it's a unique medical issue. Acute anxiety, agitation, aggression, distress, and possible sudden death. The restraint struggle and the use of electrical conduction devices, i.e.,
Taser.
tasers, um, to cause death raises controversy, and recent research points toward central nervous system dysfunction of dopamine signaling that causes delirium and fatal autonomic dysfunction. Victims of excited delirium usually die from cardiac arrest, although the cardiac exact causes of cardiac arrest is likely multifactional and chronic. Unfortunately, an adequate treatment plan has yet to be established. Did you hear that? An adequate treatment plan is yet to be established. Although rapid sedation, followed by closely external cooling, IV fluids monitoring, and treatment of potential medical complications are among the most potent sedative agents, have been proposed to stabilize excited delirium victims. While there's still much to be discovered about this pathophysiology and treatment, it is hoped that the extensive review will both provide police and medical personnel with the information necessary to recognize and appropriately respond to excited delirium. Uh, my comment on this excited delirium, and this was from 2011, is that we're probably seeing excited delirium in a lot of the cases where police officers, somebody was in custody by the police and went into cardiac arrest. I firmly believe it was excited delirium. Yes, it was maybe an excessive force. Yes, they were tased. Yes, all this happened. But the thing about it is, we can't let them up. We got to hold on to them, but we got to be conscious and cognizant of the possibility of this patient having this excited delirium syndrome and dumping that dopamine. Comments. I'm going to leave it at that, and we're going to try another one here. Nope, that didn't work. So we get there. The police have got them, handcuffed, sedated. We get there. The jail's got them in their comfort chair. That's what they call that thing, I believe, in it, David, a comfort chair. Where
Quiet
they,
chair.
a quiet chair? Yeah, it's not quiet at all.
Yeah.
We need to stay calm. We don't need to harm the patient. And we're going to get this patient with that's really extreme combative behavior.
Transfer to something. I'm okay.
We're going to go down here and look. So we're going to need to know, like the paper said, we need to keep them calm. We need to aggressively, rapidly give them something chemical to sedate them, to get them down. We need to worry about the hypothermia. These patients have hypertension, tachycardia, diaphoresis, dilated pupils, tachypnea, abnormal tolerance to pain, and endless endurance and strength. And they're doing it and they're putting it all out there, and then all of a sudden it collapses. And that's where they get into respiratory and cardiac arrest. And the restraints may increase the risk. Um, they may have drugs on board, head trauma, substance. So uh, you can see how that would cause problems with law enforcement and jail officials, how they want to try to deal with this. All right. I'm going to be quiet for a minute and let somebody else speak about excited delirium or
Hey, Casey,
agitated delirium. Yes, David.
sorry to interrupt. We just got a call
Go,
for a
buddy.
little fracture with a subaxial on something. So I'll be taking a trip to Springfield here in just a little bit. I'm going to try to stay on as much as possible.
I want to ask you questions. I've got Matthew out there, and I think I got Devin out there still.
Yes, you do. I'm listening.
Okay. Yeah. Jason, how about you?
I'm still here.
Any excited delirium stories you wish to share?
I prefer to chemically restrain those folks.
I would too.
I actually prefer chemical restraints over any other restraint. I mean, I'll IM you some Versed, and then we won't have any more problems.
Well, I like the environmental, moving people around and talking to them.
Yeah, I've just never had, and I'm pretty good at that, but I've just never had any kind of luck when someone's truly having an episode that is uncontrollable.
Oh yeah, no. When we get down to the excited delirium part, everything's out the window. You can't talk to those people.
This is remarkably along the lines of delirium tremens or the night terrors or whatever you want to call them.
Right.
Your symptomology. I mean, I just went and pulled up DTs and your symptomology, and I think if I read something correctly on your deal just a little ways up, it had that alcohol withdrawal was also one of the common side effects.
Yes, sir. And people that usually abuse alcohol and get into drugs, they tend to run into law enforcement, and then they get incarcerated, and then they get acting out, and then they gonna show them, and then here we
Well,
are.
that's the problem with law enforcement is, and I'm not against law enforcement. I realize they got to do what they got to do, but they also, you're not going to not behave for them. They're not going to lose this argument. So most of the times that means they're not even going to back up from the argument and take a long, strong look at it. They just realize they've got the might makes right, and right makes might. And
Yep.
sometimes that gets a little bit, gets them in and puts them all in a position.
True.
I'm not trying to beat up on law enforcement at all. That's not my point.
I'm not either. My son works in law enforcement, but now I've also seen it both ways. But they need to be restrained. They need to be put in a quiet chair if they're causing problems. But then by the time we get there, they're in cardiac arrest and they're going, well, we just strapped them in the quiet chair. They need to be aware of this syndrome.
Right.
And I think that might be some of our education there. Okay. Speaking of might makes right, Senator Schumer has just called for Trump's immediate removal from office under the 25th Amendment. This is going to get interesting. Who knows? He may have excited delirium.
Brain death or severe mental incapacity is the 25th Amendment.
I don't even know what is going on, to be honest with you.
I don't either.
I think you just give them all a big dose of ketamine and get rid of them and replace everybody in 10 minutes.
Hey, don't talk like that. That's treason.
Yeah.
Sedition or something. We already got a guy from Northwest Arkansas sitting at Pelosi's desk.
Oh, that was my favorite picture. The one thing to remember with excited delirium, especially if you're working a substation in the county and you do chemically sedate and transport, you know, those patients, you need to be monitored. Like Brian said, you're fully responsible for that patient. But what comes up must go down, or however the saying goes. Those patients will wake up, so you have to be hypervigilant in, watching those patients, seeing if they need to be resedated again, and also in the back of your mind, being aware of reemergence syndrome, where sometimes excited delirium with ketamine intensifies the situation and potentiates it.
Oh, okay.
And you're right, Jacob. These people are burning through everything really quick. So there's a lot of monitoring has to happen to these people with the level of metabolism they have cranked up at that particular moment. They're going to burn through a lot of stuff. Your sedative meds, any meds, sugars. There's a lot of things happening to them.
True.
You can always do O2 therapy. I think that's illegal, though.
As in the tank?
Yeah, exactly.
Holy mackerel.
Casey, could you roll up your go up screen, or that way?
Yes, sir. Do you need me to send you this National Medicine Excited Delirium?
What, if you don't mind, I would like to know the causative agents of it. I mean, do they have a?
It's from the National something on something here. I don't know what NCBI is, but it is a National Institute of Health.
I would say we probably all seen these patients and just didn't call them by name.
Oh yeah. I'll put this in the chat area for you. I think I can do that. Did I do that already?
I don't see it. All I see in the chat area is a green whistle.
Oh, hang on. I'm trying to get back to it. Okay, stop share. There we go. You know why I didn't? It's not down there. There it
You put
is.
it there.
All right. Anybody else? I had to step out. I had a phone call. Sorry. And Brian, did I lose you?
No, I'm here.
Okay. I had that in the chat area. I just didn't hit enter. So there you go.
Thank you.
No problem. Enjoy reading that one. And you're probably correct that we have seen this more than we realize. So just be aware that when you do take charge of them, you are responsible. All right. So the last thing before we go to lunch here is going to be suicide. And I've got something here for suicide. Here are the risk factors for suicide. This comes from your friends at the Center for Disease Control. And suicide is considered a disease. So they've got risk factors. Family history. If somebody in their family is committed, or excuse me, suicided, then there's a chance they could suicide themselves. By the way, they don't commit suicide. It's called suicide or suiciding. Family history of child maltreatment. Those are people that are more risk factor to suicide. Previous suicide attempts. If they have attempted suicide in the past, then that means they could do it again. Mental disorders, especially those people with clinical depression. Alcohol or substance abuse, feeling of hopelessness. If you spend all your money on alcohol and drugs, that's going to make you hopeless. So those people, suicide. Impulsive or aggressive tendencies, they are suicidal. Cultural and religious beliefs, um, the suicide is noble, that sort of thing. And what was the group out in California that the comet came and they were going to leave on the comet, so they all took medication and suicided?
Heaven's Gate.
Heaven's Gate, yeah. And then down in
I
Jonestown,
was thinking Scientology. I don't know.
Scientology, Jonestown, down in Guyana, they all drank the grape Kool-Aid and suicided because they didn't want to be, they didn't want to be handled by other folks. Um, there can be local epidemics of suicide where one person does the suiciding deal, then the other people say, hey, that's cool, so I'm going to do the same thing. And there's suicide pacts. I'm going to suicide. If I suicide, you suicide, and that happens. Isolation, barriers to accessing mental health. If you live in a county that doesn't have mental health capabilities, uh, then you have that. Loss of work, of relationships, or financial, that can lead to suiciding. Physical illnesses can lead to suiciding. And easy access to lethal methods, i.e., the butcher knife, i.e., a weapon, i.e., a tall building, i.e., a tall cliff, water, you know, you know, in cases, some people even take their vehicles and cross the center line and hit 18 wheelers head on, and that is a lethal method. And if they've got to the point where they have decided what method they're going to use, these people need help. But they are unwilling a lot of times to seek help because of the stigma that's involved. But we need to get them to know that the stigma is the cure is not as bad as the disease. So there we go. We've gone through all those. Um, they, as I said, PTSD is another one. access to firearms, loss of a loved one. There's seasonal times that people get wrapped up with. Well, we just went through Christmas, and a lot of times Christmas makes you think of family, and then you think of family, and then you think, well, this one's gone, this one's gone, my brother's gone, my sister's gone, my parents are gone. I might as well go too. And we get there, and we've got to talk to these people, and we got to kind of determine, do they have a plan? Is there a lethality on it? There has been some great classes out there, and there is a Velvet Shots teaches a suiciding class about not how to, but how to work with these people. And there is some interesting steps. There is some suiciding first aid, and I want to get away from saying committing suicide, because if you commit suicide, if you go up to somebody and say, "Are you going to commit suicide?" Instantly they think if you're going to commit something, that means you're going to break a law. So that doesn't help. But if you say, "Have you contemplated suiciding?" you kind of soften it up a little bit and open it up so they will talk to you. So that's part of this class. There was a 2 day intense class that I went to on suicidal first aid, and you get to these people, you talk to them, you bring them in, you get them to agree, you get them to talk to you. It's kind of environmental stuff. And then you find out what's their plan. If their plan was their car, was they will take their car and go run into another person, you take their car keys and you get their car keys. If they're going to use a firearm and they're going to shoot themselves, you say, okay, well, we'll agree that we're going to take the bullets out of the weapon, put the bullets one place, put the weapon another place. So they've got to think about it. If they're going to use the weapon to kill themselves, to suicide, they got to get it all together. And that sometimes, by just separating those two environmental things, it helps them work it out. Pills, same way with pills. You can remove the pills or get someone else in their family to take charge of the pills. Um, and you do follow up with them. The course is so intense, and you do a lot of role playing, that the first day, the first 8 hours, at the end of the first 8 hours, they don't even let you take your books home. They make you put your books down, and they tell you go out and decompress. I mean, you almost get PTSD from the class. Has anybody else taken this class?
I've never heard of it.
I have not.
Jake, it's surprising because this Velvet Shots is from the trauma center in Springfield.
Huh. That's interesting.
And she has an interesting story she tells in it. And her son suicided, and the crew that picked up her son knew that she was at the level 1 trauma center, and they took her son to the other facility in town. So yeah, and she talks about her son, and it is really, really, really a great class. And they've been putting them on. The health department's been putting them on. So if you get a chance, I will get that information and we'll put it out someplace, maybe in the maybe on the web somewhere. But anyway, I'll get that information to you. They're great classes, and they are 16 hours. It's 2 days, and I took mine over in Bentonville, and that's where she's at now, and it was a great class. Uh, but it makes you think about suiciding from a different perspective. All right. Any questions? Anybody got anything on suiciding?
Well, if it makes you sleep better at night, prior to becoming a serial killer and while studying psychology, uh, oh crap, what was his name? Ted Bundy worked for the Seattle Suicide Hotline.
Ah.
Just the more you know.
Yeah, that's kind of interesting. All right. We've all seen people out there that have a desire to uh, hurt themselves. And this is one that we can do something about. Now, I'll give that CDC website and put it in the chat room if anybody's interested in it. Brian, did you want to say something? Or are you just adjusting there?
Always adjusting.
Okay.
I'm old. No, I don't have anything. I could wax on like everybody else. We've all dealt with people who have committed suicide or
don't say commit. Don't say commit. Say suicided.
Okay.
That's really the wave that this class teaches you.
We have all dealt with people who have killed themselves. How about that?
Suicided. Just not commit suicide. Because you don't commit suicide, you suicide or you're suiciding. You go to this class, that's what they teach you.
I'll have to go to that class.
I'll find out about it.
I would. It would be an interesting thing to go be part of. I absolutely think that we've all dealt with it, and it could be a benefit to everybody. Never underestimate the stress that puts on you.
Oh, it does.
I think something that, getting down into the raw of it and stepping on my own toes here, but I would venture to say we probably all thought so many calls that we go on for suicidal ideations. Well, they've not done anything, but they say they want to commit suicide. And I will be the first to say that I just kind of brush these patients off and in my head go, well, if you're just wanting attention, if you were serious about this, you wouldn't have called 911 for help. You would have just done it and have not really given those patients the proper care they probably need from an emotional standpoint.
Well, one of the first things they do in this class is to teach you to figure out whether or not they have the capability of suiciding. Have they planned it? Number one, do they have a plan? And it goes through several things. Do they have a plan? Have they thought about it? How are they going to do it? Do they have the forethought of it? Are they just seeking attention? And you can pick up on that one too pretty quick. But that's part of that class. I'm sorry, I interrupted the discussion.
No, I've always lived under the theory that they don't have to have access to anything. I've seen people be successful with suicide with zero, what one would consider zero opportunities. And if they're phenomenally dedicated to the proposition, you're probably going to get called to the aftermath and not the forehand. The problem is where in my opinion, where the rub comes in is we may have been called before they finally made that decision, before they finally really made the real decision that said, I am doing this now. We may have hit them several times, days, weeks, months beforehand, that we could have made a difference and didn't make a difference, or probably didn't take it as serious as we possibly should have. To go along with what Jake was saying, is there's probably a bunch of them that way.
Here's the Arkansas Department of Health, our Healthy Arkansas suicide prevention. Did you know Arkansas is number one cause of violent deaths in Arkansas is suicide? How about that?
Well, and the it's all sad. There's not a not sad moment in that, but then we see a lot of our servicemen who are suffering from this sort of thing.
Sure.
Now, and that should all promote all of us to be active in trying to resolve.
I'll put this out here. This is a PDF. Y'all can all open PDFs. This has that class in it. The first there's a 4-hour class called a Safe Talk, and then there is the assist class. It's the assist, a suicide assist class. Anyway, yeah, That's the one that I took.
Seems counterproductive.
Yeah, that's what I thought when I first went to it. 16 hours. That's an awesome class, and there's two areas there though that you can go to. The state health was doing these, and actually paying for you to go to them, which was pretty neat. Ta-da! There you go. I'm gonna go back to that just a minute and see where it takes me to this assist program. Anybody else have something to say? I can't believe Matt's been so quiet.
I think everything's, that I could think of has been pretty well said. I don't know. I guess just along with everybody else, we have all dealt with it and with people that have had these thoughts and have attempted. So we just got to try to talk to them and get them to the appropriate help that they need.
True. Okay, how long do y'all want for lunch?
Catch this.
Doesn't matter to me. I'm on a transfer, so y'all can make it as long as you want.
Okay.
I didn't see it this morning.
Lunch breaks, that's a real thing?
It's a real thing. You're in education. 30 minutes. Be back at 12:30.
Sounds good. I think that's more of an hour, though.
Oh, I'm sorry. 12 o'clock.
Oh, good job. Who brought that
Matt,
up?
why did you say something?
Yeah. Now we got 26 minutes.
I ate lunch when I was out. I'm sorry.
Keep your mouth quiet.
12:05.
Yes, ma'am.
12:10.
Okay, what time? Seriously.
Seriously, I think 12:12.
I think 30 minutes is good, so everyone get back on here at 3.
Sounds good.
That dog don't hunt.
Have they ever given like an actual time?
The 12:10.
Yeah, let's do 12:10.
Okay.
I think I can live with that.
All right. See you then.
See you at
Okay,
12:10.
good. My diuretics are kicking in.
Okay, bye.
Bye.
down in yonder. I'll go get it. Boy, have you been keeping up with any of the political stuff going on? I brought your glass back up here. That Razorback glass right there is your glass that you had. Go in here and eat. I brought you Dr. Pepper. What do I? Watch these Dr. Pepper. This sounds like this. What should be some training. And our Wednesday night book. Good deal. What they do. Well, we got to put it in the North box, don't we? Yeah. I mean, I gotta go to the bathroom. Oh, I love you. It's going real good. I think it's going awesome. I've learned about the green whistle. I didn't know nothing about a green whistle. Did you catch it? Freeing up. Is he freeing up? No, he's Y'all have gotten awful quiet on me, and I don't like that. I think y'all have gotten too much to eat, and
Sorry, I'm trying to get my daughter down for a nap right now.
oh, okay. Well, get her down for a nap. Heaven forbid. Okay, let's try this. Do you remember the old AEIOU tips when we're dealing with a patient of altered mental status? Anybody but Matt. Matt is putting his daughter down. Anybody else got anything?
What did you say about AIOU?
AEIOU tips. You can't see your screen, can you?
Oh, yeah, I do now. I remember you taught that in class
I
once
did
upon a
teach it.
time.
Teach it in
Yeah.
class.
Yep.
And it is the acronym for assessing altered mental patients. Typically, the number one thing for altered mental patients is alcohol. If they've had alcohol, they're going to be altered because alcohol does alter you. Then epilepsy, seizures. They may be coming out of a seizure, maybe postictal. Then you've got the insulin, that's the I in AEI, and that comes from the diabetic condition because they may have low blood sugar or high blood sugar. The next one is O, and that's oxygen, and it's usually hypoxia, lack of oxygen. Then the U is uremia, and somebody said that earlier that people with altered mental status actually come from problems with their kidneys, kidney infection. Then the tips is trauma. Trauma can cause you to have an altered mental status. Infections, psychiatric, poisonings, and that's drug overdose, legal or illegal. And then the shock
Nice.
and strokes come together. All right. So, seizures. What do you know about seizures? There's generalized and partial. Generalized is the shake and bake, not the one that David was talking about, shaking and baking. But that shake and bake there is the tonic clonic seizure. That's the grand mal seizure, if you will. And then the other generalized seizure they have is the absence seizure,
And I haven't placed right in my foot.
which
We're
means.
at dirty though. I got to put this. There we go.
Did you get it? That's the petite mal seizure, petit mal seizure. Those are the ones that kids a lot of times will get.
Hang on a second, because they canceled the game and they canceled school. So hang on.
They did cancel the game. I forget my cameras and mics on too at times. Okay. So, and then there's partial, and that's the simple or complex. Now, with status epilepticus, there is the treatment here from the American Epilepsy Society. We'll see if this one will open up. You hear Brian? And this is the SAGE journal. This is the Institute of Epilepsy Currents. And you can read treatments here on what's the best way to treat um, epilepsy. There you go. It is available. And you can click on it, and it will give you everything you ever wanted to know about current epilepsy. And that's November and December of 2020. And they're looking at seizure reductions greater than 75% can leave more room for life in little victories. Pretty neat. And that's for patients under the age of 2. Lots of reading. Lots of reading. Good material out there for you if you needed to go look things up. Um, they say static epilepticus is a continuous seizure lasting more than 30 minutes. Remember, static epilepticus is a true emergency because if you have two or more seizures without gaining consciousness between them, or longer than 30 minutes, or a prolonged seizure that lasts 5 to 30 minutes, should be treated as status epilepticus. The problems is they can have bone fractures, brain damage from lack of oxygen and depletion of glucose, hypoglycemia, and dehydration and aspiration. All of these can occur with status epilepticus. Now, what causes these people to have epilepsy? Number one thing, and we all know this happens, is that somebody has a seizure and we get on the scene and we ask them, are you on medication? Yes, I'm on medications. Have you been taking your medication? The answer is
I get a lot of yeses.
you do?
I do.
Really? Matt, I always get those. I just ran out, or my prescription is at the pharmacy, or I
Yeah, I get.
can't afford it. And that is usually the cause of most seizures because they are non-compliant with their medication. They should be taking their medications faithfully, but their prescription just ran out and they have not been taking it. And now they've had a seizure and they call us and go, I don't know why I had a seizure. You didn't take your medication? Oh, does that have anything to do with it? The answer is yes, it does. Now, we also get seizures from kids. Sometimes this time of the year when they're having fevers and sicknesses, and you get this rapid increase in body temperature, which is known as a febrile seizure, and those can be quite scary. Okay. And when that occurs, we just need to cool them down. Um, put them in a tepid water bath, put them in the tub, let them cool off on their own. Typically, once you cool them off, they're better. Usually, a lot of times, the parents will take the child, it has a fever, and they're going, do I start a cold or feed a fever, or do I feed a fever and sweat a cold? Anyway, they take these children and wrap them up in their snow outfits, and it's not snowy outside, and they shoot their feet temperature up, and then they have a seizure. So, yeah, it can be from an infection. Another thing they call it hypoxia, lack of oxygen, TBI, traumatic brain injury, that can cause a seizure. Alcohol, drug withdrawal, stroke. Can pediatric kids have strokes?
Yes.
Yeah, it's a very small amount, but they can have strokes. Hypoglycemia, that's your blood sugar again. Eclampsia, they got to be pregnant for them to have an eclamptic seizure. And when they have a seizure and they're in preeclampsia, they've gone from preeclampsia to eclampsia, and y'all know that. They can have seizure disorder, electrolyte disturbances, and poisonings. So if you get a pediatric patient that's been throwing up for several days with diarrhea and they have a seizure suddenly, it may be an electrolyte disturbance. Okay. So what are you going to see? Brian, you got this one? What are you going to see when you come upon a seizure? Seizure.
Seizure?
Seizure. Yeah.
Well, everything from, well, most of the time, 99.9% of the time, by the time you arrive as a pre-hospital care provider, you're going to see a altered mental status, post-ictal state, confusion sometimes, aggression. That's all secondary to a hypoxic state caused by the seizure. I have rarely made it on scene to an active seizure. And those that you usually make it on scene for an active seizure are either repeating having a secondary seizure or you're in deep kimchi. You're pretty big trouble if they're still seizing by the time you manage to get on scene.
That's that static epilepticus, which is a true emergency.
What I have found as a general rule for my pediatric febrile seizures is the parents have not given them a damn thing, pardon my French. And you're right, they were cold, so they wrapped them up because they were having chills. I would strongly urge you to run to your ibuprofen Tylenol cabinet first thing and give that to them, maybe even before you started active cooling if you can, because tried active cooling from Omaha to Harrison on a child who was topped out my glass thermometer. I'd never seen it before. Matter of fact, I handed it to Larry Gillum to have him look at it so that I could confirm that we thought it was close to 106. It went off the gradient scale on the glass tube. Shook it down, did it again, looked at it, then handed it to Larry and said, "What do you see?" And he said, "Good God." And I said, "Yes, that's what I saw too." And we actively cooled and dropped the child about a half a degree to 1 degree. And that was pouring water on them, cooling all their, trying to keep them from shivering, but doing everything we could.
Oh, yeah.
And if we would have given Tylenol or ibuprofen up there by the time we got to Harrison, the antipyretics would have probably kicked in, because that's what they did as soon as we walked through the door in Harrison. I knew the parents hadn't given any because I asked them as soon as I got there, and they said no. And I said, "Do you have any?" They said no. We didn't at that time. That was approximately 2 weeks before we started carrying that on the ambulance. I can tell you why, because I had a fit about it. And it seemed like a very no-brainer. But do get in there and give them your antipyretics as quickly as you can, because that's what's going to really bring the temp down and hold it for a little bit.
Here, here. Very good. True, true.
Did Brian say glass thermometer?
He said glass thermometer. He's old. He's old. We used to have
It probably had mercury in it too. I don't even want to talk about it.
We used to have two, one red one, one blue one, and I forget which one was which because it tasted different.
Oh, that's gross, Casey.
I'm sorry, it's true. Yeah. So let's see. Spasms, we talked about that. Jerking, sweating, cyanosis, especially during the seizure activity, increased secretions, incontinence, and postictal state. We usually get there postictally. That's where they're at when we get there, unless they're waking up and they're getting agitated and carrying on. So, what do you do for them? Well, you keep them from hurting themselves, right, Tara?
That's right.
It's
Remove all objects that could harm themselves. Make sure you pad under the head.
Yep.
Do not stick anything in their mouth.
Especially your fingers.
Absolutely, unless you're wanting, workman's comp forever.
Or be called nubbin.
And don't try to hold them down. Don't try to force them to stop doing anything that they're doing. Protect their head.
Look, it's their seizure. They want to have it. Let them have it. Hey, like that.
Also, watch for any secretions that may come out. Be ready to flip them to their left side. Suction if needed, which is, the one thing that's the hardest in the world for me to do is that sound.
Sorry. She quit talking. Okay. She was doing good. I said, sorry.
I had to just be absolutely everything for that one.
IV, IO, yeah. Provide emotional support because they're going to ask, what happened, what happened, what happened? And then consider benzodiazepine, a good old Valium. Get ready to have it. You get it ready. You might need it. You might not, but follow med control. Do what the doc says. All right?
I've had and when I woke up, it was like I went to sleep. It was so quick that when I came out of it, I was embarrassed because I thought I had fallen asleep donating blood. I had no idea.
Gosh. Why did you have a seizure donating blood?
I was a stupid teenager. Can we leave it at that one?
We'll leave it there. We'll leave it there. All right. All right. That's it for that one. We're going to go right into the next one, which is immunological emergencies and anaphylactic reactions. A little bit of both here. Not going to take long. We only got a half hour for this one, too. There we go. Go back up. Can you see me? See what's going on here? Here's another one of these journals from the National Institutes of Allergic and Infectious Diseases, the Food Allergy and Anaphylaxis Network. Um, they've actually gone in and done studies of this. This is their little chart that they've come up with, um, how to look at these patients and how to look at their anaphylactic reaction as it occurs. I'm sorry. Yeah, there you go. Whenever you get one of three of these criteria fulfilled, then you're having an anaphylactic reaction. If you get flushing hives, angioedema, pruritus, and either respiratory compromise or blood pressure, decreased blood pressure, syncope, incontinence, then if you get any of the three of these, then you have anaphylaxis. Um, and that's category one, category two, category three, as you see across there. Persistent GI, and then also blood pressure being down. And this is just them coming up with a easy way to for EMS people and for emergency people to figure out, did they really have, are they really having an allergic reaction? So, gosh, that is there. So remember, an allergic reaction is nothing more than hyperactivity. It is a immune response to an allergen. You know, whenever you get involved with something you're allergic to, you instantly start itching. You may start sneezing. You may start, having some of these localized symptoms, and it's localized. It's just in one spot. You might itch on your hands. I got into something the other day. I don't know if it was a fragrance inside some of this new alcohol cleanser or not, but I cleansed my hand and instantly they started itching really, really bad. And that was a localized reaction. Now, there was some histamine released, and I did get redness and some urticaria down there. I didn't get involved with the GI tract, but I could get them nausea and vomiting, and it's minimal. It's just go wash your hands, get it off of you. Uh, and if I get exposed to it again, then it could lead to anaphylaxis, but it not necessary. Most of the time, it's just an allergic reaction that is localized. It happens in one part of the body, and it is taken care of. Um, some people have food allergies. They'll eat something, and as soon as they get it eaten, they start sneezing or something of that nature. So, that that can be quite troublesome. Uh, so that's localized. Now, anaphylaxis is different, where the allergic reaction is very concentric, localized, one area, one part of the body. Anaphylaxis is entire total body. It is chaos of the whole system. It is not just a localized reaction. It's life threatening. And what happens is, instead of a little bit of histamine being released, there's a lot of histamine that's released. And that histamine spreads throughout the body, causes widespread vasodilations, capillary permeability, so you leak fluids out of your system. If you get big enough fluid loss, you can go into shock with it. You can get bronchial constriction, and then there is mucus production. So your breathing tubes constrict down. You get mucus inside it, which furthermore blocks it down, and that leads to respiratory distress. The tongue swelling in the upper airway, and then there's airway obstructions. Now, there are people, believe it or not, there are people out there that have put their anaphylactic reactions on YouTube. they had the forethought when they were having an anaphylactic reaction to take their phone out, put it on record, put it on a selfie stick, and record themselves going, "Look at my tongue swelling out of my mouth." Ugh. You know, I don't understand people. I just, if I'm having an anaphylactic reaction, I want somebody to come and help me. And I'm going to tell you what that help is in just a minute. But anaphylaxis is a life-threatening situation, and it is large amounts of histamine. It is respiratory distress, respiratory obstruction, can lead to full cardiovascular collapse and cardiac arrest. So, what do you do for these people? I'm opening it up for y'all to talk now. I've talked enough. I'm going to take a drink of water.
Intervene quickly, Benadryl epi, and then be ready to assist in someone's airway. Like y'all be taking that thing pretty quick, so it don't close off.
Good deal. Ensure adequate airway ventilation, oxygenation. Keep the SpO2 above 94.
We also need to make sure that we.
Say again, sir.
I'm sorry, I'm done with my call now. I'm gonna say a little Benadryl to knock the histamines down, maybe about 100 of Solumedrol.
Okay, go ahead, Tara.
Also making sure to remove them from the actual instigator of it.
Very true. Very true. Good old-fashioned epinephrine, first-line drug of choice. It reduces that histamine. It also clears up the bronchial dilation, and it causes vasoconstriction. Where you've had bronchoconstriction and vasodilation, epinephrine just reverses it, just switches it back. And you got to constantly reassess. But you got to remember that epinephrine doesn't last a long time. What does it do? Short half-life. So epinephrine may need to be what?
Repeated.
Repeated. Thank you. Right. Somebody said Benadryl blocks that histamine receptors. It doesn't get rid of the histamine, but it does block that receptor. So diphenhydramine or Benadryl is a second line medication. And then what did you give us the third one? Medication?
Yes, sir. Solumedrol.
Solumedrol. Solumedrol is used to stabilize the cell wall. Very good. And how about albuterol? Albuterol works.
Bronchodilator.
Bronchodilator, yep. Now, this is interesting down here. This talks about some statistics from the emergency department, diagnosis and treatment of anaphylaxis. 57% who presented to the emergency department with anaphylaxis can be misdiagnosed. And nearly 80% of those correctly diagnosed was not given epinephrine as the first line treatment. What? We'd never do anything like that, would we?
I think it is much more socially acceptable. People don't feel near as sticky about giving them 50 of Benadryl as they do giving them their epi.
We don't want to give
right, wrong, or otherwise.
We don't want to give them epi. Their heart rate's already what?
Elevated.
Yeah, way up there. So, we don't want to give them epi. Gosh, epi will make their heart explode. I was looking for the answer to this stuff here. I don't see it though. They usually give me when they write a paper, they give me a conclusion. I don't see a big conclusion on this one. It must be a long one. And this paper, this white paper here, is Emergency Department Diagnosis and Treatment of Anaphylaxis, a practice parameter. And when did they do this one? It's Elsevier did it, and Don't see a date on it, but anyway, looks like it's some pretty good people involved with it. They printed it in the Annals of Allergy, Asthma, whatever magazine that is. And that's their category of evidence. So obviously, you got to have any one of three criteria is fulfilled, you have anaphylaxis. That's supposed to help them make the decision whether it is anaphylaxis or not. And that's that visual thing. All right. Anybody got a good anaphylaxis story? I'll give you one. I ran on a mayor of a small town that was allergic to bees, and he got stung, and he carried his own epinephrine and dihydramine. He had a little plastic box. We're going to talk about age now. A little square plastic box, and in it had two syringes. One was epinephrine, the other one was dihydramine, and he had one Benadryl tablet in there that he took. And by the time we got to him, he was still doing okay, and he had reverted. He had stopped his anaphylactic reaction with his own little medication kit. I thought that was pretty neat that they would give somebody their own little kit to use.
I would have to be honest with as much as it's talked about and preached about. I think I have given Benadryl a couple times and epinephrine maybe one time in all the time I've been on an ambulance. Just hadn't seen a lot of those calls.
Just lucky, I guess.
I guess.
I guess.
I know a lot of the schools have been ramped up on education with the school nurses and also the government funding for them to get EpiPens to be able to administer it to students. So I think education has come a long way in anaphylactic treatment for the lay people and being able, well, before EpiPens jumped sky high, for people to be able to get them and hold on to them and use it as needed.
Oh yeah. In fact, it was a state law passed that anybody that had an EpiPen could use it. They didn't take any specialized treatment, and they were even giving it to camp counselors.
So that makes you wonder, Brian said he hasn't used it or hasn't seen very many of it. Is that the proof that education and being able to give it to camps and nurses, that it's cutting down on the number of calls for EMS for that?
Well, I would think that not being the case, because even after they have an anaphylactic reaction, they need to go to a facility to be taken care of, because they can revert to having a second one of those.
Well, just like you said, that Epi's half-life is pretty short anyways. It's going to be a quick fix till you can get some immediate help.
True. I'm looking up the next stuff. Y'all bear with me here. Oh, me. All right. Y'all are being nice and quiet and being very nice to let me get where I needed to get. Uh, okay, let's change gears from anaphylaxis and immunological stuff down now to the model uniform core criteria and the implementation of the model uniform core criteria for mass casualty incidents triage. And if you go out there, it sends you to the um, ems.gov. And when you put it in there and you look at, here's the PDF for it. And this is the Department of Transportation. Y'all all can see that, right? I am sharing my screen.
Yes.
Okay, this is the Model Uniform Core criteria for mass casualty incident triage. Some people go their entire career and never get involved with a mass casualty incident. The hospital trains on it. They go through drills on it, and we're drilled up pretty good. Now I don't know now with the pandemic if we're going to continue getting drills on it, but some people get pretty much so squared away on it. This is their paperwork on it. Their little brochure, and it's quite a nice little read. And if y'all want me to, I will put it in the uh, in the chat room down here, so you can visit it. Um, CDC has its own 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 guidelines on field triage of the injured patient, and this is the CDC's reading on that. As you can see, there's lots of words and they're little bitty, but there's lots of, oh, there it is. Let's see if we can see this thing. Don't think we can. Let's see. Well, I used to be able to zoom in on it. I don't think I think I just did, didn't I? Well, poof, what did I do? Hey, look at there. I think I found something out. All right. This is the 2006 CDC Field Decision Guide. And this is where you go in and determine vital signs and level of consciousness. And this is their trauma center guide. And we're not going to go with that one because that's 2006. I got a better one than that to go to. But NHTSA says here that we should follow our education standard for operation in our rules and regulations, safety of patients. And we need to be looking at general considerations, global sorting, life-saving, and individual techniques. If you go back and remember some of your basic first-time training on field triage with mass casualties, didn't you all use the RPM method? Is that the one y'all did as you come to
Yes.
the patient? Okay, yeah. And the first thing you did was got on the intercom of the PA system of the ambulance and said, everybody that can hear my voice, move over to that, tree, or move over to that mailbox, or move over to that, yellow tarp, or, the green tarp. You take a green tarp, hang it up, and go to that green tarp. And those people all become your what? Walking wounded. You just triaged about 60 to 70% of your patients. It's really easy to do. And then you can send someone over there to kind of keep them corralled, keep them checked over to make sure nobody that is green is going to the yellow side. But those that are on the ground now are yellow, red, or and black. So four colors we use: red, yellow, green, and black. The stoplight, if you will. Red means stop. We got to do something. Going to take lots of assets to get this patient taken care of. Yellow means, with a little caution, these may be okay. We're not going to have to do a lot of resources with them, but we can impact on whether or not they survive. Green, they don't need anything. They need a ride. They need off your scene. That's what the greens need. Greens need a bus, a van, something to pick them up and take them someplace else. And don't take them where you're going to be taking your reds and your yellows. Then there is the black, and those people don't care because they're DRT, dead right there. They do not need to be taken anywhere. If you're dealing with a mass casualty incident, usually you're dealing with something that's going to involve someone coming in and investigating it later on. Some of y'all may have worked bus accidents or plane accidents or, train accidents, an accident that involves the National Transportation Safety Administration. They come in, they want to know where everybody was at. They're going to ask you things like how many souls on board, where were they located at, where did you come into the scene, what did you see when you entered the scene. I was very fortunate to work uh, a not a charter bus, but a routine bus wreck. Uh, routine. What do you call that? Scheduled bus route. We had a scheduled bus route that ran from Little Rock all the way to St. Louis. And the one night they were coming through Jonesboro, Arkansas, and he came in on a road. He was a temporary driver. He came into a road where the road teed, and he did not tee. He took that big over the road bus right out through a rice field. And when he got stopped, he had one woman that was thrown through the windshield onto a rice levee, dead. We had several still inside the bus were injured from where the wheels actually came up through the floorboard of the bus and broke their legs. And we had one guy that got out, got his suitcase, and was headed to town because he didn't want to be involved in any investigation. Don't know what he was carrying in the suitcase, but he didn't want anything to be in that. Um, one of the anecdotal patients that I remember was the gentleman sitting behind the bus driver, and he was a truck driver, and he had been involved in a truck accident someplace down in Texas, and they offered to fly him home on an airplane or ride the bus. He said, "I'm not getting in them airplanes. They crash. I'm gonna ride a bus."
Mistakes were made.
Yes, they were, and that was the biggest thing was meeting with the NTSB later after the accident and trying to explain to them where they were at, how we did what we did, when we did it, and it was an eye opening experience. And if anybody else has had anything like that, let me know because it was really quite intensive. But go ahead, somebody's wanting to say something.
I was going to say in Abilene, we had a plane crash. It was like a private, and there's only like 5 people on board, I believe. And I think only one survivor. And that's what those ones that were black upon initial arrival. We just left them there. One guy's head was like through a tree, and there was all kinds of messed up everywhere.
Yeah,
This,
you don't
but
move them. You
nope.
don't move them because NTSB wants to know where they're at. Um, in fact, the bus wreck, we finally bagged the lady, but before we bagged her, we had to put flags next to the body, next to the head, and the coroner had to come out and take pictures. It was quite an extensive thing because it was a transportation accident involving a carrier and a licensed carrier and something else. Anyway, so, but the big thing was the triage. And if you're going to go down now and look at those red ones, remember we said the red ones are going to take lots of resources. In a multi casualty, mass casualty situation, you don't have a lot of resources. Basically, when you get on the scene and you call for a mass casualty, hey, Rube, everybody's coming, but when they're not there yet, guess who's in charge? You are. You're in charge. What resources do you have?
You and your partner, basically.
And what's on the what? Truck.
Yep.
That's it. You know, you may have some well meaning first responders there. You may have some well meaning lay people there that have brought their box of band-aids and come running. I mean, I'm laughing, but now it's serious. You got to take them into considerations. If you got those people there, they work very well with those folks that are green. You put them with the green folks and say, now, if anybody passes out over here, you come and get me and let me know. If they pass out over there, they're no longer green. Now they are probably yellow and hopefully not red, because they're this, as they say, um, as they say in disasters, um, it's fluid, very fluid. What does that mean? Well, it means it's constantly changing. You don't know. Um, Look at that. Could you imagine being the paramedic on standby at the nation's capital, and you're standing by because the senators and the representatives, they may have a health issue. You're not a whole lot going on, and all of a sudden the Capitol is overrun with rioters and people up to no good. Uh, Boy, you talking about a mass casualty. Then you hear there's shots fired and woman is down. That would chill you to the bone, because then you got to say, is the scene safe for me to go in, because there's still active rioting going on? There are people still occupying and tearing stuff up, and I've got to respond to that. And now the Capitol Police have shot somebody. Well, the good news is the Capitol Police are cross trained. So once they shot this young lady, they actually stepped in and started trying to save her. Now that's kind of interesting in its own part, because law enforcement shooting somebody and then turning around and trying to save them. But yes, um, that would be chaotic. That'd be a crazy scene. I know the bus accident was a crazy scene. I'm sure Matt will tell you that plane crash down there was a crazy scene. Those paramedics in Little Rock that ran in on that American airliner that overrun the end of the runway, crazy scene, because they got all these people and you don't know what to do with them. Um, Brian, were you involved with the train exercise with the Branson Scenic Railway?
Yeah, we played with that.
That was crazy. That was a crazy scene in itself, and it was a drill.
Right.
Um, yeah. So, you know, you got to use the red, the yellow, the green, and the black. And then the red ones and the yellow ones, the three things you check is respiration, pulse, and mentation. Respiration, pulse, mentation, RPM. Why? Because if you get into a triage situation, you've got to rev up. You've got to get those RPMs up, because that's where you're going to check off on the red and the yellow patients. So check with that RPM and make sure that they have all those. Now, the they use the salt, they use the start. Start is what we believe that Arkansas looks at, and I told you the R is respiration, P is the perfusion, and M is the mental status, or respiration, pulse, and mental status. Start really works. It works, and that's the one the state of Arkansas has signed off on for us to use. So therefore, we should use it. Um, it kind of goes along with the salt, and the salt is sort, assess, life-saving intervention and treatment transport. Global sorting, that's what you do when you get there and you say, you walking wounded, go over there. You that ain't walking, just lay there, we'll be with you. And then you do the RPMs. They both are the same. They both work together, and it's taking care of a lot of people in a short amount of time with very, very, very limited resources. Let's see. I thought this opened up yesterday when I was in here looking at this stuff. Up. Nope. Let me see. We've looked at a lot of magazines and stuff. EMS.gov is a good place to go get information for that. HealthyArkansas.gov. That is the Arkansas Department of Health. And if you put in here TRI, oh wait, I messed that up, didn't I? Triage. There is the emergency communication system. That's the trauma survey, the syndrome surveillance rules and regulations. There's our emergency coordination center that we deal with. There we go. In the trauma part of this, there we go, is the Arkansas, there's trauma bans. There's the trauma rules and regulations. I thought it was there. Hang on a minute. I'm sorry. Maybe it's here. Maybe it's in this thing. That looks like a mock-up. Shoot. Right at the end of this thing. Nope, that's the rules. Sorry. I apologize. Thought I could lay my hands on it, but I can't. Oh. Oh, right there it is. Right on the very top. Why didn't I click on that, Brian? Why didn't you straighten me out? The one we looked at over in the national CDC was a 2006. This is a 2013, and we'll look at this one because this is our field triage decision scheme for the Arkansas Trauma Triage Protocol. It is exactly the same as the national one with a couple of corrections because we go a little bit beyond what the national does. Here again, first thing you do is vital signs. First of all, how many has not seen this?
I bet everybody's seen it.
I don't know. That's nobody. Me and you are here, Brian.
But well, I just speak every once in a while just so you'll keep counting me here.
Well, I appreciate it. I'm just to the point of, well, we're here and we're going to talk about this and we'll just.
I'm still here.
Oh, Todd's here. Good, Todd. Thank you, sir. Todd's got the snow going on down there in Newton County.
The snowpocalypse?
Yeah, the snow.
David's preoccupied.
Okay. David's preoccupied. Okay, so we get this triage scheme. We get the vital signs, level of consciousness, and we go, okay, what is the Glasgow Coma Scale? Well, if it's less than 13, it could be considered a major. If it is less than 13, we say yes. We go over here. What do? Look, we contact ATCC. Who is ATCC?
Trauma Control Center.
Yeah. And we contact them, and they tell us where to transport to the most appropriate hospital. The most appropriate hospital, according to the ATCC, is one with capacity and capability of handling our trauma patients. Okay, let's go on. Let's say we're above 13. Well, we don't need to call them then. If the blood pressure is less than 90 or age appropriate hypotension, then we say yes, we contact ATCC. If that doesn't work, then they got to be less than 10 on their breasts, or greater than 29. And then that's age appropriate. So those are all majors, and we need to contact ATCC for that. Okay. If they don't fall into those three categories, Brian, where do we go?
Wherever we want.
No, we go to no. Then
Okay, sorry.
we assess the anatomy of the injury. What is this anatomy of this injury? If it's a
I like my answer better.
I did too. All penetrating injuries to the head, neck, torso, extremities proximal to the elbow or knee, in other words, close to the knee or elbow, then that's a yes. Then we got to go call ATCC. Chest wall instability. This is flail chest, deformity of the chest, call ATCC. If two or more proximal long bone fractures, so two humeruses, two femurs, two tib fibs, two radial ulnas, yeah, then that's a yes. It's a major. Contact ATCC. Crusty glove, mangled, pulseless extremity, ATCC. Pelvic fracture, ATCC. Open depressed skull fracture, ATCC. You get on the roll here, paralysis, ATCC. Well, if we haven't got any of that, we can go to the no, and then we go down to looking at mechanism of injury or evidence of high injury impact. So those only two that we talked about up here, less than 13, less than 90, less than 10, greater than 29, are all those penetrating long bone fractures or paralysis. All of those are the majors. So now we don't have a major, we got to go to a moderate. And a moderate, we look at other things. If you fell greater than 20 feet, in other words, you fell 2 stories, if you're an adult, or if you're a child and you fell off a 20-foot ladder, that's 2 times your height, then that's a fall. That's considered a moderate. Guess who we contact? Altogether, y'all supposed to say
ATCCC.
ATCC. There you go.
ATCCC.
CC, senor.
So if it's a major, do we have to contact a major at ATCC?
No, you don't have to contact a major at ATCC. Just contact ATCC and tell them that you have a major trauma.
I didn't know if you had to go major to major.
No.
Okay, sorry.
It can be major to dispatch. As long as the dispatcher is at ATCC. Then there's moderates, as we said, falls, high risk auto crashes. What's a high risk auto crash? 12-inch occupant site, or 18-inch anywhere. So get out your ruler. The car's now 22 inches shorter than it was. That's a moderate. You need to contact ATCC. Ejection, partial or complete. If they got injected from the vehicle, they're a moderate. No matter if they're up walking around, still a moderate. Contact ATCC. If you have a death in the same passenger compartment. Now, if that was a death in the passenger's compartment and then they run off the road and stopped in the grassy median because the driver had a heart attack, don't contact ATCC. It has to be a trauma. So they'd have to have a heart attack driving down the road, run off the road, hit a tree, then you contact ATCC because there's a death in the passenger compartment. Okay, the next one, this is the OnStar one. If OnStar calls you and says, we have a major crash, then that's going to be kinematics considered with high risk of an injury. You're going to contact ATCC. Auto versus pedestrian, auto versus bicycle, run, thrown over, or significant crash greater than 20 miles an hour impact, ATCC. Motorcycle or ATV crash greater than 20 miles an hour. That says a motorcycle crash or an AT crash, you don't have to ask because they're all going faster than 20 miles an hour. Contact ATCC. That's your moderates. Okay. Now, if you don't have any of the ones above, the 3 above, then we slip on down here to the button, this last box. And that is assess for special patient or system considerations. I kind of resemble this one, Brian. Risk of injury or death increases after 55. So if they're older than 55, contact ATCC. If their blood pressure is less than 110 and they're 65, contact ATCC or consider consultation. Low impact mechanism, ground fall, which might be a severe injury. you can consider talking to ATCC. Children, triage preferably to a pediatric sized trauma center. Anticoagulation medication or bleeding disorders, ATCC. Burns without trauma, take them to a burn facility. Trauma mechanisms with burns, then they need to go to a trauma center. If they're greater than 20 weeks pregnant or your EMS provider judgment, contact ATCC. Then they'll send you the most appropriate hospital. If you haven't got any of that stuff that we talked about above, now, Brian, you can say it. Transport them to where?
Wherever you want to go.
Wherever you want to go. That's right.
Wait a minute. With consideration for the patient choice.
That's right, and that's going to be a minor patient.
And not Clinton. You don't ever take anyone to Clinton. They don't want patients.
Yeah, it's not a hospital. Don't even go there.
What?
They want to go to St. Louis.
What? Well, that's going outside your region's area. Oh, by the way, I got to say this because my friend down there at the ATCC said I've got to say it. When in doubt, contact ATCC. It's not when in doubt, whip it out, but when in doubt, call ATCC for direction. And they will be more than happy to tell you where to go.
That is the story of my life.
Uh-huh. Questions on the field triage decision scheme. Now, the mass casualty, you're going to go up there, and what's the first thing you're going to do?
First thing is yell out if you can get up, move away, initiate incident command.
That's good.
Is the scene safe?
Is the scene safe? Good one.
Stripe test.
Yeah. Y'all are going so good. Keep going. Highland, that don't work.
You're going to call for additional resources.
May have to call for additional resources because if it's beyond your scope of practice or beyond your resources, you're going to need some help because you're going to need help just in filling out all the paperwork that you're going to fill out here. Trust me, I worked the Jonesboro school, West Side school shooting. Paperwork. Oh my gosh.
Yeah.
Yeah.
I supervised a huge bomb threat up in Springfield one night in a very heavily occupied apartment complex, and it was really good experience. Got you thinking outside the box. I was able to commandeer multiple CU buses, and the city buses up there, all the seats laid down. You can actually essentially clear the floor. I could have put 20 patients in per bus, laying flat. So
wow.
It was a good resource, but it was that was a fun night.
Yep. It's always good to know that stuff. And it's always good to know where your nearest refrigerator truck is at so you can store the people that are dead. Happens. All right. So we've talked about that. We talked about that. I'm trying to think of what else we need to talk about. Well, that didn't go nowhere. Sorry. Some of these worked yesterday. Now they're not working. Don't think that's it. All right. We're looking up Jumpstart. We'll see what that says. Oh, there it is. I'm looking for Wikipedia. No, I'm not. Oh, that's the. There you go. So here is, in case y'all haven't seen this one, this is a neat one. This is the jump start for pediatric triage, and it's pretty easy. Number one, are they able to walk? And Jake, you might say yes, and that would make them a minor patient, and you'd send them over to a secondary triage. If they're spontaneously breathing, yes, then you go to their respiratory rate. If it's less than 15 or greater than 45, in other words, if it's 15 to 45, you go down to pulse, yes, then you go down to an AVPU, alert, painful, verbal, alert, verbal, painful, unresponsive. And if you get a P, then they're immediate. If you get an A or a V or a P, then they can be delayed. Pretty easy scheme in itself. And if you don't get spontaneous breathing, then you got to go over here and you move them to immediate. And notice green, yellow, red, and black. There's your colors. Except this one right here, and it goes to a secondary triage. Do we need to put this in the chat area for those folks that may want to look at it? Brian? Ah. So anybody that wants this jump start for pediatric, it's now, the link is now in the chat area for you. So I think everybody's gone.
Nope, I'm still here.
Okay. Do we need?
I'm not gone.
Do we need to take a break for a minute? Go to the bathroom, adjust ourselves, do whatever. Or do y'all wish to keep rolling? We'll keep rolling. We need to roll.
It's whatever. I mean, I'm in the bathroom right now with you, so whatever you need to do.
More than I wanted to know. More than I wanted to know.
Good one, Jason. Good one.
Yeah. Okay. Where is that? Central nervous system. Don't forget, job's not done till the paperwork's finished. Huh. It says the next thing we're supposed to do is CNS. There it is. All right. Found it. Now we can go with it. Screen shared and there and here and there. Okay. So we're looking at central nervous system disorders and injury. We're staying in the trauma realm. Probably the biggest thing we have with CNS trauma is going to be TBI, traumatic brain injury. You've all seen them. You've all seen people with concussions, but traumatic brain injury, this is probably the worst of all things that you can have. I'm thinking about people who have high-speed car crashes with head injuries. They present with headache, nausea, vomiting, balance problems, dizziness, visual disturbances, light sensitivity. They have mental fogginess. They're in the fog of their injuries. We see people that um, feel slowed down. They can't get up to speed. They can't concentrate. They can't remember. And because they can't concentrate and they can't remember, they're irritable. They're sad. They want to sleep all the time. They're depressed. And there is a way for it, according to ATLS, figuring out where this person's TBI is located. If you get somebody 13 to 15, that's a minor brain injury. Good news there, Matt. I'm 13 to 15 all the time, so I guess I'm in that shape right there. 9 to 12 would be a moderate. And then if you get anybody less than 8, not only do you need to intubate, but that's a severe brain injury associated with this traumatic brain injury. Um, there is, and that also sets into play whether they're a major or a moderate uh, call on the trauma patients, that trauma scheme that we saw. Uh, the people that have traumatic brain injuries typically go other places after they're stabilized to be rehabbed. There's a big hospital out in Colorado that deals with traumatic brain injury, and they take their time and rehab these people and teach them how to regain their living capabilities. And some of these folks that have had these significant traumatic brain injury accidents can be recuperated back into the workforce. Now, questions, comments on TBI? Some of y'all may know the area vac uh, paramedic that was involved with the car crash on 412, and how his TBI was taken care of, and now he's back and he's becoming a community paramedic. So his effects have run full gambit. And if you haven't heard that story, it's out there. His testimony about the trauma system and the helicopters and EMS, and which you guys played a significant part. North Arkansas Regional Medical Center played a significant part in getting him taken care of, and then the helicopter from here flying him out after he had just left the helicopter here being on duty. It's an interesting story.
Casey, that was my call. We were the first truck that responded, me and Brian Duncan.
There you go. And you and Brian responded, and who is it? Carrie and
Well, and Vince and John, they came as a second truck, and then Carrie was on air vac.
Right. And he speaks highly of you guys taking care of him on the scene, even though he don't remember it.
Well, I hadn't been doing it very long, so I wasn't too much help. I was kind of in panic mode, but
panic mode may be the best way for you to be, because he got over it, and it was quite a crash. Okay, care and education of the concussed patient. Now, what are you going to find out about a patient with concussions? Anybody ever dealt with a concussion patient? Anybody ever dealt with a concussion patient?
Yeah, I don't think they're good sources of.
Anybody ever dealt with a concussion patient?
Yes, can you hear me?
Anybody ever dealt with a concussion patient?
Anybody ever dealt with a concussion patient?
Concussion? What's that?
Just again, they ask you repetitively, what happened, what happened, what happened. They don't remember. They do not remember. And one of my most interesting runs, I had a patient that was concussed, and he kept asking over and over. And finally, his wife said, "Can I answer that question for you?" And I said, "Sure." She said, "You were abducted by aliens and they probed you." And I went, "Where did that come from?" And she was having the biggest time, because she was coming up with story after story after story. Every time he asked, "What happened?" she would come up with a new story. And I guess that lessened her stress. It did lessen my stress. I sat there and enjoyed the whole thing. Uh, but if you you have suspicion. See, I've got my mouth about wore down. if you have suspicion of concussions, you need to take them to appropriate facility. Where's the appropriate facility for a concussion patient? Boy, it got quiet again. Where are we going to send?
That's a Cox South.
Cox South? Yeah, that might be all right.
I took there. That's why I would say that.
Okay. That would work. Anybody else got an idea? Remember what we said on that trauma triage scheme a while ago? When in doubt,
Call ATCC.
Call ATCC. There you go. But you don't have to worry about calling ATCC most times, because what happens is the patient with the concussion may actually refuse transport. I don't want to go. Oh my, you've got to go. The rules say you've got to go. You've got a concussion. You got to go. Is that true? Can we forcibly take somebody to the hospital?
He's talking about the trauma.
It's going to depend on the patient. I mean, you're going to have to assess orientation and alertness, and that might end up being one of those sedated patients you end up having to deal with if they're not, completely coherent or alert and oriented.
Remember,
Contact med control too.
There you go, Matt. That's where I was going with that next statement. Was remember, if you think they need to go, contact med control and see if you can get them involved with it. But if you can't get them to go, then you're going to have to give them some warnings. And of course, the one that I hear all the time is, if you don't go with us to the hospital, you could have a traumatic brain injury and die from that injury if you don't go with us. Well, the 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 thing about death is, if you put that out there as you could die, a lot of times they will go with you just because they don't want to die. Um, but you're going to have to look at stuff like, is one pupil larger than the other? If they get drowsy and they can't be awakened, if they get a headache that gets worse and just doesn't go away no matter what they take for it, if they get weakness, numbness, decreased coordination, repetitive vomiting, that projectile vomiting, slurred speeching, convulsions, seizures, you know, difficulty to recognize people and places, who are you, increasive confusion, restless agitation, you know, any of this stuff, then they need medical attention. And you may have to tell the family members this, because they may need to hear it from you, so they will be watching for this. Now,
4-6 or queen.
Go ahead. CDC has come up with sports concussion policies and laws, and this is information from parents, coaches, and school and sports professionals. And I recommend that if you go and stand by at sports games, that you get out here and read this heads up concussion sports policies, and you look at it. It's from the CDC, and you can download it. It doesn't cost anything, and you need to know what you can do and what kind of efforts can go on. And it's interesting that the legislation. Everybody in the nation has enacted legislation for this concussion protocol, except Mississippi, South Carolina, and West Virginia. And Delaware, I think, hasn't done it. But anyway, it's interesting that they haven't done that. Um, and you need to remove the athletes from play if they've had a concussion, and then get permission to return to play. And that may be after 24 hours with the permission of a doctor. And it's pretty extensive, but the CDC has it out there. And if you would like that PDF, I will put it in the chat. How about that? Oh, I've got 3 chats now I need to look at. I think I got too much open. Sent that one out now. Okay. All right. And then you can utilize entitled CO2 readings as a guide to assist head injury patients. How in the world is that? This is some old standards here, because this is where it tells you to mildly hyperventilate the patient in the field to keep their entitled CO2 between 30 and 35. We all know that that's what? Not prudent. We should not ever hyperventilate a patient, because if you hyperventilate a patient that has a head injury and then they quit hyperventilating them, then there is a paradoxical rise in their ICPs. So don't do that. Don't do that. And spinal precautions, long spine board, that's kind of gone away, and that's another statement on long spine boards. Comments, questions on central nervous system injuries?
Nope.
Y'all being awful quiet. But these are half hours. We're getting through here pretty good. But I am willing to listen to y'all if y'all want to talk about something. Todd, I'm going to have to get you to take this next one because my throat's getting a little bit scratchy.
Oh, yeah?
Oh, yeah. You can do this one. I got faith in you, Todd. You know what it is, Todd? Hemorrhage. How can you tell they're having a severe hemorrhage?
The big puddle of blood on the floor.
That'd be a good start there, Matt. What else?
Hemodynamics.
Sure.
Hypotension.
Hypotension, sure. Those are all good ones.
Depending on what stage, whether their heart rate's going to be increased or decreased, if they're compensating or not.
Compensation, non-compensation. Yeah. Those are all good ones. But what would you consider a major hemorrhage? I think that was the question, wasn't it? Severe hemorrhage, yeah. Severe, major. That works.
I think just like Jake was saying, it's going to be how they're hemodynamically presenting. If they have signs of shock and blood pressure's down, heart rate's up.
Y'all beating all around the bush. Y'all are absolutely right. But if it's not controlled by direct pressure, you put direct pressure on it and blood runs out around your direct pressure, guess what? It's a severe hemorrhage. If it is a severe hemorrhage, how are you going to stop it if direct pressure doesn't?
Tourniquet.
Yep, tourniquet. And that's how we tell whether we're going to use tourniquet or not. Did direct pressure stop the bleeding? If it didn't stop the bleeding, then we got to move on to the next part, and that is the tourniquet.
That's like the guy we had with a grinder blew up and hit him in the face. I knew I forgot to put the tourniquet on him.
Wait.
No, I'm joking. I'm joking.
Okay, good.
I'm joking. I'm joking.
I got a little excited there for a minute.
Yeah, he was arterial bleeding from the mouth, and his like face was cut open like the Predator, and I was like, okay, here we go.
Here we go. Direct pressure, and maybe what did you use? Did you use one of those Israeli bandages on him with the hemostatic impregnated gauze?
Nah.
Nah.
No, we just grabbed what we could at the time, which was in that. We kind of went in we went in a little lackluster because we got called for a lift assist, and it was a grinder that blew up in the guy's face. So we were like, oh boy. So we were using towels. Yeah, we were using towels, and then it was like continuing to arterial bleed. He was compensated at that time. Then he quickly went decompensated whenever bleeding was not stopping. We gave TXA and tried to RSI him, get him flown somewhere else.
Did you get him somewhere else?
Yes, he's back home now.
Oh, good.
He's doing good.
Plastic surgery is a good thing. They can make him look better than they did. We can rebuild him better than he was.
That's what they needed to do for him. I know. I think his mandible was dislocated. Like his teeth were all intact, but it was like his palate was halfway gone, and it was a pretty bad one.
Yeah. Except when they run, when they rebuild them, they go $6 million man.
I was wondering why he changed his name to Steve Austin, but
there you go.
Whatever is going for him.
Now, if it is controlled, can't be controlled, then use tourniquets, and that's in extremities. And now there are some special tourniquets that go into into the inguinal area that will help cut off bleeding down there. There are some special type tourniquets. There are junctional tourniquets is what they're called, I believe. And it's where they meet with the torso up in the shoulder. Some of those are pretty interesting. Junctional tourniquets, they are with the junctional bodies. Let me see here. Y'all hang on just a second. I'm going to go out here and I'm going to find some of these because this stuff just is interesting. I got to look at this stuff the other day, and there are some pretty interesting junctional tourniquets. Sam makes a junctional tourniquet. Okay. Let's see here. All right. Are y'all all where y'all could watch a video if I showed it to you?
Hi guys, Zach here. We're going to be going over the application of the same.
I got to get the volume turned up or something. Hang on a minute. All right, here. Optimize. Share. It looks good, doesn't it? Well,
Zach here. We're going to be going over the application of the SAM junctional tourniquet today, designed to be used on inguinal bleeds. When placing the SAM junctional tourniquet, be sure to stay below the inguinal ligament. Slide the belt under your patient, positioning the target compression device over the area to be compressed. Hold the target compression device in place and pull both brown handles until you hear an audible click, securing the belt in the area. At this point, you want to inflate the target compression device.
And you just air those up, and those balloons press down on the the femoral artery.
Until hemorrhage is controlled.
If you have a pulse, it's not tight enough.
If the target compression device is directly over a wound, be sure to use a hemostatic dressing or combat gauze. Just like any other tourniquet, it is imperative that you annotate time of application on a DD 1380 combat casualty card.
Okay, what'd y'all think about that? Hello?
Sounds pretty interesting, actually. I kind of like the idea of that junctional tourniquet.
Mm-hmm.
Be good to carry on ourselves, yeah.
Right, and they're not that expensive. I think when I looked at the prices on these things, I want to go to shock. Yeah, they're $300 basically, but you know what's somebody's life worth? And there's a SAM one, and there's another junctional tourniquet out there that's not done by SAM, that's done by another agency, and it actually has individual tightness. You tighten it up by twisting a thing on it that actually helps. You know, here it is. It's the it's a junctional tourniquet, but it uses screw type devices on there to actually help get it down. I don't know what the name of this thing is. Huh. Okay. But SAM's a big one. It's the big junctional tourniquet. Jet, that's it. It's a Jet tourniquet. Let me see if I can get a video for the Jet. Y'all want to see a video on the Jet tourniquet? Y'all aren't helping me out very much right now.
Casey, I'm at work with a whole line, so I'm listening to you as I come in and out testing people.
It's fine with me.
Okay.
But there's 9 of y'all on here, so I don't know. That's the SAM. That's the SAM. I guess I need to go up here and go with the Jet, J-E-T-T, J-E-T-T, Jet. Jet junctional tourniquet. There we go. I don't want a long video. Let's do this one right here. It's about 2 minutes. Y'all ready? Here we go.
Yep, that works.
Hey, it's Kurt. We're going to go over the Junctional Emergency Treatment Tool, or JET. This is used for junctional hemorrhage on the lower extremities. We're going to go over the quick application of this. So first, you want to take the actual JET, route it underneath the small back of the patient, bring it down underneath the buttocks around basically around the superior iliac crest of the pelvis. Move your pressure devices into the pressure location, which is in between the iliac crest pubic symphysis, right in the natural crease of the leg. You can feel for a pulse if you need to. Place your pressure device there. Secondary on the other side, if it is a bilateral, you can place both. If it's a unilateral, just the one side application for this. Connect your Fast-Tech buckle. Tighten down the strap to secure your pressure devices in place. And on the affected side, or if it's bilateral, you can twist both at the same time. Twist until you get enough
Same
pressure.
idea, except this uses a pad and tightening with the windlass.
To occlude the artery. Reach down, check for a pulse.
It's working.
I have no pulse. Use the securing device. routed through the handle itself, pulled back, and tightened down. Again, always remember to reassess if we're moving the patient or putting the patient on a litter to reassess and make sure you have hemorrhage control. As with any tourniquet, make sure you mark the time of application. The jet tourniquet actually has a spot on it to mark the time, so you can annotate the time on there, as well as the DD 1380 combat casualty card.
So that's the jet. You see the other one. So yeah. Comments on that one? Did y'all hear that okay?
Yep, heard it pretty good.
Okay.
Yeah, no comments.
All right. So they're out there. They're about $300, $400 per. But those are the new junctional tourniquets. And this is for those people that have their legs amputated above without a stump. So you can't put a tourniquet on it because there's no legs there. So they use these JET or SAM junctional tourniquets. And they basically are at the Y, at the inguinal area. They put pressure right on the femoral artery. And one of them uses a pressure device, a balloon, and it can blow up one side or it can blow up both sides. And the jet actually has windlass that you tighten down and they push down the pads in there. So both of them work really well. Now, I was asking Matt about his patient he had with the arterial bleed. Did you not have hemostatic agents there, that impregnated hemostatic dressings to use? We've kind of got away from the powders. They used to talk about the powders that was out there to put in. And this is a Elsevier article, pre-hospital hemostatic agents, the review of the systems and how these agents work. And how they feel like they work, and they work real well. I'm trying to get to the conclusion. There's the conclusions. And this is 2003, 7 criteria for ideal pre-hospital tropical hemostatic agents. Quick clot, Hemocon were the ones that they studied, and they found that they worked extremely well. Quick clot and Hemocon should be considered in the current standard wound stat, combat gauze, and Celux may be more effective than hemostatic agents. So the gauze, impregnated gauze, Israeli bandages and stuff like that should be used more than the powdered agents because of the effectiveness of it. So it's just kind of stuff that's out there. There is a powder that goes in. The gauze doesn't allow the wound to get near as nasty and it heat up. If you got a bleeding that can't stop, direct pressure, put this on and it works fine. It does enhance the clotting factor. And what did you say y'all give that? What was that other drug you gave?
With TXA?
TXA, yeah. Trans-ischemic acid. Yep, it's one that helps there. The problem with the clots is after a period of time, the body starts breaking those clots down. So if you got somebody that has a big major injury and you got a clot that is set up, over a period of time, the body will start to break it down. TXA stops that. It stops the breaking down of that clot and it stabilizes the clot and it will help the patient. So research now for use out of hospital is really showing good results. Clinical trials have shown reduced death by bleeding with TXA treatment if given within 3 hours of the injury. So TXA after 3 hours may have an increased risk of death by bleeding, but if you get it there within 3 hours, they don't bleed to death, and TXA works extremely well in stabilizing the clot. Okay, good deal. But that's all, folks. We're going to the next part. Brian, did I lose you? Todd, did I lose you?
Nope, I'm still here.
Okay, you did a good job teaching that section. I appreciate it.
Thank you very much.
Okay.
Hey, Casey.
Yes, Brian.
I am sorry to be rude. I have to step away and do some other duties.
Other duties as assigned. I understand. We'll continue on without you, sir. But notice I'll be seeing you in the morning.
All right. Y'all be good.
All right. Carry on, sir. Okay. This is at-risk populations. Todd, this may be some of your folks down there.
At risk?
Yeah, because aren't your students subject to human trafficking? Aren't your students subject to domestic violence?
Yes, sir, they are.
Unfortunately, they are. And there are training sites out there. This is the Homeland Security Blue Campaign for human trafficking for law enforcement and federal employees. We basically fall into this, so we can. This is a place where you can go out there and pick up a quick couple of hours of training. If you go there to law enforcement, it'll talk about this is the training for it. In fact, if you have a CDL and have a CDL to drive a truck, they actually make you take this human trafficking awareness program. And what it basically says is, if you're out and about, and by the way, David, is that you going down the road out there? Is that what I'm hearing?
It is. We're still traveling on the way back.
Yeah. Well, if you happen to go by a truck stop or a truck pull off and you see a van full of young girls out there near that truck stop, they may be human trafficking.
I'm going to report it to the Popo.
That's right. That's what that training is all about, in that human trafficking. And it just teaches you to watch for different things and use them. So, there is a characteristics of the at-risk population. Pediatrics, they get people of wide range of development from neonatal to young adults. Sometimes these kids will be nonverbal or highly communicative. In other words, you may go and bump into somebody that is being human trafficking, and they may be talking their heads off to you because they're wanting you to know that something's going on with them. They may have injuries patterns. They may be dependent on adults for protection and prevention. You can have domestic violence on geriatric patients because they're fragile. If they have injuries that are far more risk than their age, then you may look at that. Polypharmacy is common. They may have certain drug interactions. You need to be aware of medical overdoses. Age-related cognitive impairments, dementia, and delirium. Dementia can be mild to severe, and delirium also, and they'll lose their independence. They won't be able to be able to do things on their own, and they may have a reduced uptake of certain medications. Now, in the domestic violence, there is a training out there for that one, and this is the basics of domestic violence. Notice the big bruise here to the girl's face, and this is some more training that you can get into when you want to learn some more about this. And it's free training. It's good stuff for you to know about. It will enhance the way you take care of patients out there. Domestic violence are likely to occur to the following anatomical sites: face and arms, face and neck, head, back, buttocks, breast, abdomen, and genitalia. That's where the domestic violence takes place. The people that are doing domestic violence do it to their face, the arms, the buttocks, the breast, the genitalias, and a lot of times they have injuries that are in different stages of healing. You have some that are green, some that are red, some that are fresh, some that are old, and your bruises may be in various stages of healings. They may have scars and mutilations. They may have problems with going to the bathroom, pregnancy, rectal pain, pelvic pain, chronic back and hearing problems, cardiovascular, as a result of forced manual labor in unsafe conditions, poor eyesight, malnourished, disorientation, confusion. That's why a lot of these places now have stickers in the bathroom that these kids, when they're being human trafficked around, they will actually have bathroom stickers that says, if you are being trafficked, call this number, and it has a number for them. And we as professionals should be watching for these at-risk people because they are unreliable historians. If you start asking this young person questions, they're not going to be able to answer them. They're not going to answer them correctly. They may be looking to their handler, to their stable master, their person that's over them for their information. Um, they may not be able to give you their medications or current therapies. They may have a reliance on their caregivers, also known as their supporters, or also known as their, as I said, stable masters. They will look at them to get your answers to them. You need to assess the environment which the patient's found. Are they underdressed? Are they overdressed? Are they inappropriately dressed? Uh, do they need supportive care? Do they need treatment for injuries? Document your finding and know the state laws on mandatory reporting for abuse. And I'm here to tell you right now, we are mandatory reporters. So we need to be putting that information out there. If you see something, say something, especially with trafficking, because there is some awareness that needs to be done out there. Okay, hang on a minute. Okay. I think this is the one we want to watch. Yeah. All right. Blue campaign. Here we go.
Did I lose y'all?
No, we're running a video. Can you hear it? It'll be coming up here in just a minute.
I can hear it.
Soliciting for the purpose of prostitution, recruiting underage girls for the purpose of prostitution. Talk to me, Erica. What's going on here?
I had no choice. Alex made me do it. I did what he said, or I got beat up.
You think this is some kind of game? We need the money, bitch!
I don't want to go. I don't want to go.
I don't care what you want. It's what we need. Because if you don't, I'm gonna mess you up just the way your dad messed up your mom. You understand?
And it happened. Just like that. They said we were going to a truck stop. By then, I knew what that meant. I was scared, but I didn't know what to do. I should have never texted him. That was the night I pulled my first trick.
Gosh, you're so easy to talk to.
So are you. It's like we've known each other for a long time.
I can be myself around you. No games.
I know. I feel the same way. No one understands me like you do.
Same here.
I'm not appreciated here.
I appreciate you. You know what? Screw them.
I know, right?
I want to give you the world.
I can't wait to meet you.
Okay, you know how this works. Keep your cell phones on, wait for my directions. Don't try to call anybody, because I'll know. Got that? What? Don't act nervous. Guys don't like that. Here. Take these. Focus. Let's go.
Hey, just take it. It'll chill you out. All right? Just make sure you look out for cops. Come on.
I love you. I want you to live with me.
I don't know.
Baby, don't you love me?
Of course I do, but I don't have a job and it's so expensive to live around here.
I'll go into my savings. I'll do whatever it takes. You're so worth it. What the hell are you crying for? You know we're in debt. Do you know how much money you owe me, bitch? Where you gonna go, huh? All you got. You gotta step it up.
I thought you loved me!
I do, but you're a big girl now, okay? If you really love me, you're gonna do this for me. Okay, you know how this works. Don't act nervous. Guys don't like that.
Hey, just take it. It'll chill you out.
Okay, how was that?
That's how I feel about a day after a payday. Well,
Yep.
my money.
Well, my money. Yeah, there you go. But that's what we have to be part of, is that awareness that going on. It is going on, and whether we believe it is or not, it is going on. It is out there, and we need to be part of the solution to it. This is called the Blue Campaign. It's put out there by Homeland Security. I'll put this in the comment section. If you're interested in seeing it or watching it on your own, please feel free to drop by the comment section, and it'll be there for you. And I'll try to save these or print these off so I'll have them. Okay. There we go. All right. We have covered this. So this would be the at-risk population. What are y'all thinking about this so far? Are you getting anything out of it? Are we wasting our time? I know that Matt's here, Jake's here. Highland is on the chat. He can't hear us.
It's been good so far, Casey.
Well, I hope so. I hope so. We're going to do one now called ambulance safety. That ought to be interesting for you out there on the road, huh?
Yeah, really.
Never make your partner angry. That's always a good one.
Especially if he's driving.
True. Okay. NHTSA has ground ambulance information out there for you. Let's see. There's some real stories behind ambulance data. That's not there. Let's see. Oh, that one's there. And this is the parts about the NHTSA and ambulance crashes. And the last information they've had out there is 2011. So it's basically 10 years old. So this is the Fatality Analysis Reporting System, or the FARS. In a crash type, single vehicle, ambulance passenger is more likely to die. All right. Pedestrians are more likely to die. Yeah. Multiple vehicles, then the emergency was in use, and then there's other things that happens. This is just interesting data. It's interesting to know that people killed in crashes in between 1992 and 2011, that 63% of them were occupants of other vehicles. We didn't kill people, but the occupants of other vehicles did. Ambulance drivers is the least likely of dying in a crash at 4%, where the ambulance passenger is at 21% and only 12% of people on the outside. Now, injured, on the other hand, the driver is 70% chance injured, the passenger in the ambulance 29, but because we drive in big vehicles, 54% were the occupant of the other vehicles. 29 fatal crashes involved an ambulance, 58 were while emergency use, 42 were non-emergency use. So just because you're not an emergency up there, David, doesn't mean you're going to get out of this. Yeah.
Exactly. Keep company.
Trying to make you feel good there.
I appreciate it.
Yeah. These are slides, and they're just going down through and talking about the crash data. They talk about seating positions and how to change things. They have done some extra work on EMS trucks, so that's a good thing. And they have a culture of safety, and that should be the latest data right there, if it'll even open, and that won't open. So there we go. All right. So there are federal initiatives developed to monitor and analyze ground ambulance crashes. There's near misses, there's close misses, all that's out there, and they keep up with that through the Department of, EMS.gov, through NHTSA, National Highway Transportation Safety Administration. They have special investigators that come out and do those special crash data. They pick up on it through the model minimum uniform crash criteria. They have participants monitor ambulance defects as well as crashes. They bring it. If they see something, they say something. That's why they've changed the way we seat in the back of a truck. Remember, We used to get in the back of a truck and we were not strapped in. Now we're supposed to be strapped into our seats. They've even changed the way the ambulance boxes have been structured as designing to crumple better, so they give us more safety inside them. By the way, just in case y'all need to know this, 4,500 crashes per year is car crash or ambulance crashes. So that's how many that's been averaged out. And that was in 2014. Um, of those 4,500 crashes, 1,500 were considered injury crashes, which injured somewhere around 2,600 persons. And 59% they were in emergency use. 29 fatal crashes a year. 29 fatal crashes a year. That's 29 more than we need. 42% of them were non-emergency, and the fatalities in the non-emergency crashes, 4% were drivers, and 21 were ambulance passengers, and 63 were occupants in other vehicles, as we said. Now, this data only indicates crashes that occurred on roadways customarily open to the public. It does not involve crashes that happened off of roads that were private roads. Not all vehicle crashes in the country are reported to the police. The police may not record ambulance crashes as accurately on crash report, and it does not distinguish between what type of ambulance. So an ambulance is an ambulance is an ambulance, whereas we know there is the type 1 ambulance, type 2, and type 3, and the crash reports don't show that. It does not determine when the crash occurred, whether it was en route to the scene or en route to the hospital, was it emergency status or not. It does not collect data uh, of the proportion of the time the ambulance is on the road. They have found now through research that a person that stays up for more than 12 hours is operating at the same capacity as somebody that has had 3 beers. And we all know how good that works out. The model minimum crash, uniform crash will provide this data and analysis if they adopt this model minimum uniform crash criteria. And that's what NHTSA is talking about by traffic accidents and tracking investigation. There are near misses and there's non-near misses. Let me see here if this is one of those that I opened up the other day. Whoops, nope, that wasn't it. And we'll try that one. And whoops, that won't open up either. So 84% were unrestrained EMS providers. Those people that were involved in injuries and fatalities, 84% of them were unrestrained. And you may be thinking, how can 84% of the people riding in the back of an ambulance be unrestrained? Well, if you're an occupant in the back, there is no restraint for you. That is why that's changed in the back. They've taken the squad bench out of some trucks, put the ambulance a jump seat on that side of the truck where the jump box used to be, and we're seeing changes in the back of the ambulance to actually provide us in the back more protection. I think it was Louisiana actually come up with a truck they designed, and it is designed to it's designed to reach 90% of their stuff from the back of the truck. Hold on just a minute, guys. All right. So 90% of what they can reach in the back of the truck is reached from the seat they're sitting on. They have right beside the patient. So they have full access to the patient, full access to all their equipment. And it's great that they have it that way. That is the exception, not the rule, but it's coming. 44% of the patients were ejected from the cot, had serious injuries. Are we restraining our patients? Are we restricting our patients' movement on the stretcher? Unsecured patients, both shoulder and lateral restraints, 33 were secured by both. 61% of patients were restrained with lap belts only, and 38 had shoulder harnesses available but were unused. So we have to evaluate, get policies and procedures in place to have buy-in from the EMS service to utilize what they have. We should consider and discuss the following questions. What is your agency's current policy and guidelines requiring securing a patient to the cot? What do we require at North Ark? What do we require at North Ark to put a patient on a cot? What is the minimum things that we got to do to have them put on a cot? Y'all tell me. I'm listening.
The seat belts, side rails, the weight restriction are the big things, and the shoulder straps.
Shoulder straps, because we don't put that shoulder strap in there, what happens? They slide right.
They can get hurt. Yeah.
Yep, they go right
slide out of it.
Top. I'm sorry. Trying to catch up on some things here. Okay. Yeah, so we got to have those. Do we have requirements of paramedics in the back of the truck or EMTs in the back of trucks? Are they supposed to be restrained?
Yes.
I heard yes.
For as much or as long as possible. If you need to get up, then
provide basic care.
You reduce the time that you're not.
Yeah. It's best for us to be seated in a position or in a place where we're strapped, and hopefully one of these days we'll get these trucks that have all this extra stuff out there. But there are some different types of ambulances out there, and they do seem to work better. They've done some ambulance crash videos too. Yeah, this I think this is the one that I want y'all to see.
We just had the most amazing family vacation. Let's go! Oh my God!
Happened just right behind me. Apparently the driver of that ambulance was inside this gas station, and then that's when they tried to take a left across all those lanes of traffic there, and then an oncoming vehicle hit that ambulance. And we just got some dash cam video into our newsroom moments ago, and it shows that accident unfold. Our partners at the Enterprise reporting there was no one inside the back of the ambulance at the time of the crash. The two paramedics, though, inside had to be rescued by firefighters because they were trapped for about 20 minutes. This involved a Brewster ambulance in a utility van. It unfolded here on Belmont Street, right next to Nissan 24, if you're familiar with the area, right around 2:30 this afternoon. Now, all three people involved in that crash that you just saw unfold were taken to the hospital. You did see those Good Samaritans run in to try to help. They were all taken to the hospital with non-life-threatening injuries.
What'd you think of that one?
Ugh. Had to be paramedics had to be rescued by firefighters.
Firefighters are the real heroes here.
I'll show y'all a video of a crash and y'all looking for the rescuers.
Yeah, you know.
Yeah. That was not the... Okay, let's try this one. One of these is one of these.
I think they missed a couple angles there.
Yeah, Casey, I see you talking during the videos, but when your computer audio is playing, your voice is not coming across.
I'm sorry. I apologize. Yeah. Did y'all did how fast were they going? Did it say?
I didn't see where it said, but it got pretty quick there before it hit.
Yeah, it did. You can tell these are paramedic dummies, because do you see this guy sitting on a squat bench, throw his hand up in the air and go, woo?
It's 5 a.m. Get up, get dressed. Get the kids ready. Drop them off at school. The day awaits. A 24-hour shift. The alarm can sound at any moment, day or night. We only have 60 seconds to prepare ourselves for what's to come. What and who will we encounter? Lives are at stake. We need to stay focused, and every decision has to be precise. Sometimes it's tough, and images remain long after the day is gone. En route to the incident, we have to prepare for what we might face. It's important to remain calm, even under difficult circumstances. During the emergency, in the ambulance, and on the way to the hospital, there are many unpredictable situations, and it's good to know that our ambulance is safe. The new Tigris Europa has been tested for safety by the German DEKRA in 2 demanding crash tests, whereby 2 realistic scenarios were simulated: the collision with another vehicle and the crash against a rigid barrier. With the first crash test, we simulated something that can happen every day on the road: a collision with another vehicle, which is, in our terms, a rather soft obstacle. The second crash was way more challenging for the stability of the ambulance's structure: a crash against a massive 120-ton wall. The results of the tests and the measured values were excellent, and the box body remained intact. The tests were specifically focused on the box body of the Tigris Europa. Due to the box body's high stability, it can be reused on another vehicle after the original chassis has been damaged. Within a year of development time, the Tigris Europa became one of the safest ambulances on the European market. A combination of space frame and sandwich elements guarantees a very high stability of the box body. The interior has been expanded and allows quick access to all the equipment and tools. All installations are positioned inside the box body, which allows a quick exchange of the chassis. The front panel and the light system have been completely redesigned in order to further improve the vehicle's visibility on the road. For the safety of patients and personnel, the Tigris Europa by Ambulanzmobile. Safety through innovation.
Well, what did you think of that one? Do what?
All right, I'm back. Sorry, I had a Rachel Bowles from the hospital called me, and apparently it kicked me off of Zoom when I answered the call. So
It did. It does that. Sorry you missed that last one. It was the new design of one of their Mercedes ambulances.
European style.
European style, yeah. You see it. Notice it didn't have a squad bench. It had two
Yeah.
captain chairs sitting on either side of the ambulance.
I know one of my crews rolled one of our Mercedes Sprinters when I was working in Springfield, coming back from St. Louis, and it tore it up pretty good.
How'd they do?
How did they do?
Mm-hmm.
They were banged up. They were both up front. They were coming back from a transfer, one of those non-emergent transfers that shouldn't be sent out past midnight for overnight crews because of safety and sleep deprivation. Yet, blah blah blah. Anyway, won't go there. This was with another health facility.
Okay.
Let me just preface that.
Sure.
But anyway, they sent the transfer against my my judgment, and I got the phone call about 4 a.m. that the crew had wrecked and rolled their ambulance on the interstate. Totaled the truck out, but they could have been a lot worse than they were.
Yeah, I lost a student on a late night transfer, non-essential transfer to Little Rock from it was Vitalink or what it was White River ambulance at that time. It was in Batesville, what is that county it's in up there? Anyway, they hit an 18-wheeler head on, and it killed the driver and manged up the paramedic pretty good. Anyway, what they were doing, what I found interesting in that European style ambulance, it didn't matter. That ambulance crashed and did not lose one light. All the lights were still blinking on the thing after the wreck. Did you notice that?
I did. I mean, I just don't know how I feel about. We can just put it on another chassis and keep going. I was like, I don't know about that.
Yeah. Another chassis. Just pick it up and put it on another chassis and keep going.
Yeah. I don't know about that.
Just wipe the blood up. It'll be okay. We'll just keep going.
I don't also get as like, but I mean, what is the most common type of injury? Is it going to be those front end injuries, or going to be like rollovers, or going to be side impact? Like they only tested. They said they emphasized 2 tests.
Frontal impact
styles.
is usually the big one. The front impact. Yeah. There are some studies out there on side impacts that are really quite scary. Side swipes, that sort of thing, slides off the road, hits a guardrail, fillets the side of the box. There's pictures out there of multiple ambulance accidents where the side of the box is just ripped off. And could you imagine if you were sitting on that side of the truck and the back wall that you were leaned against was suddenly ripped off? Yeah, that's scary. A lot of footage out there that you can go out there and search, actual dashboard footage of ambulances, and they are frontal crashes. People just pull out in front of them, just like they're not there. They pull up, stop at a stop sign, look right at them, and then pull right out in front of them. Like, and that ambulance that rolled over, they got hit there, that one that was talking about the fire department, people saved him. He actually made a left turn after the light had turned red. So he was at fault in that accident. So, yeah. So let's get on. Let's leave ambulance safety and let's get to hygiene, safety, and vaccinations because it's at 3 o'clock and we need to be moving on through some more of this stuff here. Um, Always wash your hands, right, Todd? Before patient contact, after, before eating, after cleaning the ambulance, after using the restroom, after nose blowing, coughing, or sneezing. Always wash in, wash out. Follow the CDC hand guidelines. Do y'all need to see that? I can put it out there if you want to see it. There it is right there. It says wash, 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 wash. Before moving from work to a soil on a soil body site to a clean body site, same patient, wash your hands. After touching the patient or the immediate environment, wash your hands. You know, uh, there is guidelines for, and you can actually get this is kind of cute, reports on washing your hands, and they've done research. They've done a lot of stuff out there on this stuff. Isolation, hand hygiene, and the course setting, educational slide sets. So we could go through that. We're not going to go through that. Y'all know what I'm talking about. Wash your hands, clean yourself up, follow CDC guidelines. Remove the jewelry, wet your hands, apply soap, scrub, uh, say your ABCs twice, wash your hands, rinse well, dry your hands, clean towel, air dry. Use the same towel you dry your hands with to turn off the water. Don't reach back down and touch it. If you got alcohol hand sanitizer, it needs to be 60% alcohol. It does reduce the number of germs. It does not sanitize your hands, and it does not eliminate all germs from your hands. It does not kill viruses. What did I just say? It does not kill viruses. COVID-19 is a virus.
Vaccine. Oh man.
No, virus. Um, Creates an inhospitable environment for viruses to live, but it doesn't kill them. It only makes it not happy for them to live there. It's ineffective when the hands are visibly dirty. So if you got a real dirty hands, go wash your hands first, then you can put on hand sanitizer. Uh, know that soap and water is more effective than hand sanitizer. Apply to the palm of one hand, rub your hands together, rub all surfaces between the fingers, and pay particular attention to the palms and up the wrists and back of the hands, and do that. Now, eye and face precautions. CDC, if you're at risk to get this stuff, then you need to use the ocular exposure, um, herpes, adenovirus, Staphylococcus aureus, hepatitis B and C, HIV, and the rhinoviruses, and COVID-19. You really need to protect yourself with face and hand precautions. All right. Goggles, face shields, safety glasses, full face respirators. What's that thing y'all using up there now? The Carpy? What is that thing? The hood with the fan in it. What is that called?
The space helmet.
What is that called?
I don't know.
I think it's called a CAPC.
C. What now? CAP?
CE.
CE?
And yes, sir. CAP, CE, I think.
It's called a capper helmet.
CEPSE? CAP? CAPSE.
Charles Adam Paul, Charles Edwards.
Okay. CAPC. Okay. All right, good. I told somebody about it, and they wanted me to find out some information on it. You need to have your vaccines. What vaccines should you have? Hepatitis B, influenza, MMR, varicella, pertussis, and COVID-19.
Syphilis.
Negative.
Okay. Vaccines help prevent transmission, and some are attenuated, weakened to kill viruses. Some mimic it, and some provide antibodies directly. Did somebody say no, they wasn't going to take the COVID-19?
But they need a little more research and study on the effects of it.
They need to research, study vaccines?
New ones that are, it's an mRNA. It's a new, first of its kind. So I think it needs a little more long-term results on it. I mean, you know, your polio and MMRs, you take those vaccines, but you don't still get those viruses if you take those vaccines. You know, you take this vaccine, you still get the virus. So that's a personal opinion.
Okay. So anyway, it was made available to me and I took it. So I've taken one round and I will take my next round probably tomorrow. I did notice that out in the news sphere out there, that a perfectly healthy nurse in, hang on a minute, in Portugal actually took the virus, took the shot, the vaccine, and died. But she was 41 years old, and there you go. Probably had a heart attack from taking the virus. All right. So do wear your seat belts. Do get your shots. Do what you're supposed to do, and you need to be always aware of the culture of safety, and that's a big thing with the national folks. They want you to know about this culture of safety. And what is a culture of safety? Well, it's thinking and looking at what's going on around you. Um, it goes back to that EMS.gov. There is a great deal of tracking of close calls. There's culture of safety right there. Protecting the health and safety of EMS practitioners, workforce safety, ambulance safety. They're collecting data on this and they share it out there. And the National Institute of Occupational Safety and Health, NIOSH, is actually doing some important surveillance on EMS people, emergency medical service vehicle. And look at there, COVID-19 is right there at the big part of it. And they've got an informatic on that, on EMS providers. There you go. Showing that you're at risk and your safety does matter. What are you most at risk for? Anybody care to guess? Sprains and strains. Practice safe lifting. What's that?
I said divorce.
Divorce. That comes under falls. Okay. That's the third one. Exposures to blood and body fluids. Wear your PPEs. Those are the ones, and that is your protection sheets, and that's put out there by NIOSH, and that's more than 22,000 EMS providers visit emergency departments each year from each type of work injuries. Safe lifting, PPEs, and slip resistance. All those are the informatics with that. There you go. There's the crash data. And if you want to look at crash data, there's crash data for what year was this? I'm sorry. Homeland Security put it out, but they didn't put a date on it. Somebody was asking about the different directions. Frontal crashes. Then there were module box, style roof, crashes from rear impacts, and crashes from side impacts. And roof crashes to the roof. Wow, I would have never thought about the roof crashes, would you? So, interesting data. It's out there. A lot of good stuff out there for you. Fentanyl exposure, who we are, what do we do, what do they think about us? This is our, this is NIOSH's keeping us safe as EMS personnel. Go to ems.gov and go to safety, and there you are. That is the culture of safety. It's up to us. We need to value and prioritizing our safety at work because we want to take ourselves back home. The big goal of most of us are to go home after the shift. And we got to actively learn and adapt and modify our behavior based on lessons learned from mistakes of others. And we need to be rewarded in the manner consistent with these values. So we want to take personal responsibility for the safety and act to preserve and enhance it. We want to identify and explain the 6 core elements of the culture of safety. It's a just culture. We want to develop environments in which EMS personnel are safe to report errors. In other words, you have a near miss, you need to tell somebody we had a near miss. This is what happened. Sometimes our near misses come from accidents where we might just roll the ambulance, or we might run off the road, or we might miss a turn or something. It's not blaming or punishment. It's just an opinion. It's just the culture. Um, we want to coordinate, support some resources out there through the EMS Safety Resource Center, that EMSSRC. Brian, does that sound familiar? That's that group that you were talking about, and they have lots of data that they put out there. Data-driven policies, sometimes they are things that are near misses, sometimes they're accidents, and the data sets, and when they gather data on it and see if it really happens. Is there injuries? Is there illnesses? Are there incidences? Are there educational things we can put into place to help people stay safe? Are there EMS safety standards that we need to put down? Can the EMS SRC coordinate the efforts to combine work and data completed by a whole bunch of different stakeholders and bring it together and say, look, these patients here, this paramedic here twisted his ankle stepping out of the back of the truck because the step of the ambulance was not down. Just like this that easy. Some of this stuff is really quite simple. Some of it is more detailed, but we've got to have a culture of safety where we get out there and we start looking for these things. Got to consider the question in regards to the policies and procedures of daily activity. What changes are needed to encourage and develop a culture of safety? Do you see something? Is there a slippery spot out there in the garage that you step in and you almost slip down because you've washed the ambulance and it's slick? See something, say something. How do mistakes handled by one during a patient encounter? Did you give the wrong medication? You need to have a culture of safety. You go, yes, I gave the wrong medication, and this is what we did, and this is how we clarify it. And how should it be handled if applied to the concept of it is just culture? And that's what they're talking about here, is the culture of safety. And we need to be aware of a culture of safety. It's good for us to be thinking about EMS safety.
I feel like there are 2 parts to that. Not to play devil's advocate, I do like a just culture and a culture of safety. I like the words more than sometimes I like. People think that means that nobody gets in trouble. You have to be a responsible adult. Good Lord, you're being given great power to deal with people, so you need to be responsible for your actions. With that being said, everybody makes a mistake, and there needs to be some forgiveness in this world. You can't repeatedly give the wrong medication and say, well, I owned up to it. It was a just culture and I shouldn't get in trouble. If you're repeatedly an idiot, then you probably need to be repeatedly that someplace else.
Right.
But also, any given Sunday, one of us could trip and make this mistake. And whether it's a bad process or things like look-alike meds, that's when you hunt down and figure out, can I fix this? And do I need to beat Casey because he was good enough to admit to the problem and we found a problem and we fixed it? No, you shouldn't hang the guy who's brave enough to report it. However, likely said, if you're reporting that you accidentally gave the wrong medication 20 times, you're probably going to get hung, and that's not a bad culture. That's probably what should happen.
Right. Brian, you want to read that to them right there? Because that's the fatigue in the ambulance.
I have a huge set of articles on this somewhere. Fatigue is a threat to safety for EMS personnel, their patients, and the public. There is no equivalent effort from any other high-risk industry occupation to improve worker. There is no equivalent effort from any other high-risk industry occupation to improve worker fatigue. This project created guidelines for fatigue mitigation based on the best available evidence. The project findings have the potential to bring about positive change for the EMS community. The body of work may also inform other high-risk industries that deploy workers in shifts and struggle to address fatigue with strategies based on evidence. Man, is this a sticky wicket, because we all like our 24-hour shifts. And 12-hour shifts. And when you're trying to staff, it's really hard to staff 8-hour shifts because there's just not enough EMS people out there to make it go around. But they pretty well talked about it like a plague. We not saying necessarily are perfect by any means, but at least on our 24 hours, we put our people down. And for the most part, I knock on wood, and you guys correct me, you're there, but for the most part, our people generally get to sleep throughout the night on the 24s now. But I know places that pay for 24 and expect 24 hours a day worth of work. Some of your private industry ambulance services, if they're going to pay you for an hour, they're going to have you working an hour because that's how they turn their profits. And there's no way you can say you're as effective. If you can't do CPR for more than 2 minutes without being fatigued and not as good as you were, how can you mentally be clear and correct at the 23rd hour if you've been up and working your butt off all day long? You just can't. The human body wasn't built and designed to do it. And can you function through it? Absolutely. Are you at your best? Or no, you can't be.
Nope, you're not. And they've got footage out there of EMS crews in California that have been up 24 hours, and they were reporting back to their base after being out for 24 hours, and the guy just drove into a parked car that's sitting on the side of the interstate. He just didn't even pay attention. So, yeah, that's where they come back with you. If you've been up that long, you just as well have gone and drank 3 or 4 beers and tried driving it.
I wish there was some methodology, and I don't know how you get it through to the world or how you do it. You're more clear and cognitive if you're being called out. I mean, at least this is my beliefs, and my beliefs in $1.50 will buy you a pop. You're probably sharper if you're called out at 3 o'clock in the morning on an e-call than if you are sent on a transfer at 3 o'clock in the morning. You at least have an adrenaline dump, and you're trying to get your stuff together, and I don't know, I think you get zoomed up a little bit, but I don't know how the industry will ever get away from late night, overnight transfers. And to me, that's one of the most dangerous times in the industry, simply because the hum and the drum of the road at 3 or 4 o'clock, 2, 3, 4 o'clock, 5 o'clock in the morning is nothing but a lullaby for most folks. And it seems a lot like Jake said, his argument with his super people about, I don't want to send it. That was kind of my opinion every night that we sent transfers out. It's just tough.
It is.
But then the industry cries out for, the healthcare industry cries out for these people to be mobile, that they do be able to get up to Springfield or to someplace else. And trying to get that discerned, well, which ones are emergent enough that should happen. You know, okay, I get it. There's a subset of people that have to be moved or else their life is in jeopardy. I get that. And so those people you want to take care of, but then how do you not abuse that, and where do you draw a line, and which patient equates to that, and how do you monitor it? That's a $1 million question for you puppies out there.
Yeah. One of the things we did in Jonesboro with the service I worked there, if a paramedic or the EMT partner just felt like it was unsafe for them to be under the wheel, they had the right to say, I'm unsafe to be under the wheel, and they got to come out. Not to be fired. They, periodically they'd just pull them out and let them have at least 4 hours downtime or 3 hours downtime. And it probably saved some people's lives, to be honest with you.
And that's a great deal, as long as we as the professionals on that deal are responsive to that and are honest about it. Not, I don't want to go to Little Rock, so I'm too tired. I need to not go.
Yeah, true.
But it would be nice to have that kind of out, so that somebody could just legitimately say, I'm too tired. I can't do this.
Well, and that service also worked 48-hour shifts on weekends. So there were times that you would be up 26, 27 hours, and you just kind of call and go, that's it. I'm done. I'm toast. And they'd go, okay, pull him off the truck, put somebody else on. And it worked. Okay, let's talk about one more thing. We got just a few more pieces of the puzzle here. I got evidence-based and then pediatric transport. And right now we are at pediatric transport. So there we are. They got a working group out here, Safe Transport of Children's. NHTSA was involved, National Highway Transportation Safety Administration. And they actually developed some guidelines, and we're going to talk about the guidelines for safely transporting pediatric patients. Just because they're little people don't mean they can go on the stretcher and strap them down with seatbelts, because seatbelts don't always work on them. All child seats, restraints in the ambulance should be tested. In other words, they should be following the NHTSA guideline for car seats, safety seats that they're transported in home now, or on their ambulance, or in their own personal car. Excuse me, I'll get it out in a minute. But now, if they've been involved in a crash, you can't take their seat out of a crash vehicle and put it in the ambulance, because once those seats go through a crash, NHTSA says they should be destroyed and new seats purchased. That's a little bit different from what we were taught, because I was taught it's best to pick them up out of their car seat, put them in the ambulance, and transport them in their same car seat so the hospital could look at the car seat and see if it's damaged. That's not what NHTSA says now. If you bring them in a child safety seat, they should be attached to a cot, a cot mount, restraints should be tested and complied with this NHTSA guideline. And they should only be attached to seating positions that pass appropriate standard testing as a system together. In other words, about the only thing that qualifies in the back of an ambulance with a child safety seat is going to be the jump seat, which is the one directly behind the driver. The child passenger, especially a newborn, must never be transported in an adult's lap. You should never do that. Never, never, never. It is not appropriate to transport a child, even in a child restraint, on multi-occupied squad benches. In other words, you got 3 straps over there. We can put 3 separate kids over there. We can get 3 of these transported, and the adult and the driver can ride up front. And therefore, we can bill for now 4, 5 runs, and the single thing that don't work either. All right. So NHTSA has recommendations for safe ambulance transport. If a child is uninjured or not ill, who's accompanying an injured adult, then we need to transport the child in a vehicle other than the emergency transport. Now that would go over well, but when that's not possible, then you need to put them in a child restraint. Okay, what was I saying? If you transport them in the front seat, you need to make sure the airbag position is off. Forward-facing EMS provider captain seat, appropriate size. Yeah, transport rear-facing captain seat, appropriate size. Or leave the uninjured or not ill child in an appropriate adult supervision at the scene. So, put them in a different car. If at all possible, then put them in the child safety seats. But, best not to transport them at all. Secure them to the cot, an appropriate size child resistant system. Situation 3 is a child's condition requires continuous or intensive monitoring, then secure the transport to the cot in a size appropriate child restraint. Um, I don't know what that would be on our trucks, except we just got regular straps, right? We would. Did I lose everybody? Am I there?
Yeah, I think the new trucks even don't have the
Child seats.
5-point harness in the captain seat either. I don't think so.
There was some ambulances that actually had a child safety seat built into the captain's seat.
We had gone to a system, Springfield. They were called ACRs, which ambulance child restraints. They were harnesses that basically fit the child based on weight that buckled into the straps on the cot. And insurance said that was one of the safest ways to transport children. And they weren't allowed, obviously to be in parents' arms or anything, but they were secured onto the cot and Velcroed and strapped down better than adults are even.
Well, I'm seeing that as we go through this and as I've read this thing, that the National Association of EMS Officers leads the Safe Transportation of Children Committee, which is that, what's the name of that group that does pediatric for EMS? They recommend the criteria of specifications for proper restraint of children in ambulances, and that criteria will be evidence-based and will consider safety of both patients and providers. And they need to have recommendation criteria adopted by one or more accrediting standards before setting the organization, and develop a strategy for educating EMS providers to safely transporting children on ground trucks based on the recommendations of the criteria. So there are limitations of the current recommendations, availability of restraints that's out there. What did you call the one that you were talking about, Jake?
The brand name is ACR, which is an acronym for ambulance child restraint. But they're color coordinated, basically goes off of weight.
Okay. And there's still not enough evidence out there. There's not enough evidence out there for adults in crashes and in simulated crashes, especially. So, all child restraints are only as effective as the manner in which they are secured to the cot and to the ambulance, and that's true. We got to put them in there and make sure we try to do the best we can with what we have. I love it when they put in stuff like working groups, because working groups, there is no information about this working group. It's just out there. And we need to have evidence-based guidelines. We're almost through, folks. And then we can dismiss, hopefully by 4 o'clock. So, evidence-based. What does evidence-based medicine mean to you?
I think it means that it's been studied and reviewed in case studies based, and they get large groups and put in all the data and give you the results.
That sounds pretty good to me. Well, what it is evidence-based medicine and practice are developed through rigorous scientific inquiry that informs EMS systems, medical directors, EMS personnel on the standard of care that have been vetted by research. Boy, there's that dreaded word, research. What does research mean?
Looking into what something's going to do. Somebody's been given something, and this is what's happened out of it. That gets put into the data cycle, and then
oh, you said a bad word there again too, didn't you?
Data.
Oh, I didn't say the F word.
No, data.
Okay.
Data. That's terrible. Data. It's investigation, experimentation, testing, exploration, analysis. That's what research is. That's what it says here in my Google. You know, Merriam-Webster says it this way. I like it because it says to search or investigate exhaustively, to do research for a research book, a studious inquiry, examination, a collection of information of a particular work. That is research. So we got to have research on our skills. Is what we're doing out there actually what we're doing out there doing any good?
Yes.
About this time every day, I go through this. What we're doing out there really doing any good? Yes.
Yes.
Somebody says.
Whether
Prove it.
it's bad or good, we're still either helping people or we're learning from it.
Ah. So trial and error is a good way to do it?
It is a way to do it.
It is a way to do it. But is it the best way to do it?
No, probably not your best way, but not everything can be thoroughly researched or thoroughly pre-planned and pre-measured. So it becomes a way of doing it.
Way, right?
Obviously, you would like to see evidence-based, in other words, proven that this works before you put it into a major protocol, but it had to be used at some point before you can derive the proof of evidence.
Well, the good thing is we don't have to remake the wheel. There's other evidence out there, and we start out our research a lot of times with what's called a literature study. Literature study means we go out there and we see if anybody else is doing it. Brian, you and I have had this discussion before. King Airway for basic EMTs. There is 4 or 5 states right now that allow King Airway and basic EMTs.
Right. And it should be allowed. Sorry, that's a personal opinion, but
it's a personal opinion, but let's go back and let's do research on it. We don't have to do much research on it. The papers are there. Their literature is there. These other big cities, these communities, Ohio is one. I think Minnesota is one.
South Carolina.
South Carolina is one.
Missouri, I believe.
These agencies have already done it, so we can go out there and go look. If them Missouri mules can put down a King Airway, why can't these Arkansas rednecks put down a King Airway? I mean, go ahead.
Nope, I agree.
Yeah, and that's what we have to kind of go with is starting out our research with the literature study, and we determine other people who've done this, and then from there we go from that we go into doing our own research study. And that's where we use either a double blind or a retro. Usually it's a retro study because EMS, we don't want to withhold anything. We just want to do it and see what the results were. So we can do those studies, and we can do a retro study where certain patients, number of patients, let's say Newton County got King Airways and Searcy County didn't get Airways. And then you compare the two patients and see how they turn out. And then you develop your conclusion based off of that research. And you might also get a service somewhere else in another part of the state to do the same thing. And, you might get in touch with Bubba and do it with them, or with Medic One and do it with them. But you would use another service and you would use the same thing. And then you would come together and look at your data, look what you found out, and then you would make a conclusion. And the conclusion is what we've been reading
when we read these scientific papers, read the abstract and then read the conclusion, and abstract tells you you're matching apples to apples, and the conclusion tells you what we come up with, and then we can decide from what we come up with, is this valid or not? Can we use it or not? And if not, then we can go back and say, but more studies have to be done on it. So research never ends. It is cyclic in nature. And you knew I was going somewhere with this. Right here it is, cyclic in nature. The process is cyclic. You know, we start out with system inputs. We start out in evidence accumulation and evaluation. We start out in literature study, and then we establish priorities and guidelines, and then we put the protocol development in place, and then we do the dissemination of those protocols. Then we implement them, and then we evaluate our effectiveness. And then the evaluation of that effectiveness comes down to the evidence is accumulated, and then what do? We repeat it. We take the system inputs, and we go right down again. And it's cyclic, and it goes over and over and over and over as we go through the research. This is from a group called the National Association of VMS Officials, and it's not found. Ha 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 ha. Sorry. And it's still not found. Okay, so anyway, let's go back. But they actually have aids out there to states, and this was a statewide implementation of evidence-based guidelines. And NCCP was awarded a grant. Heaven forbid somebody gave them some money to do it, focusing on pediatric patients to implement evidence-based guidelines on pre-hospital pain management. And the patients benefited from this grant. And they ensured high-quality patient management, standardized, consistent approach, and provide successful through expert practice and clinical evidence. And that is the benefits from going through this development of this EGB. Evidence-based guidelines. That's what EGB is, evidence-based guidelines. Evidence-based guidelines. Yay. So, this is the process. It is cyclic. Does it ever end? No, it does never end. What about our AHA, American Heart Association guidelines? Are we ever finished with those? What happens every 5 years with those?
Got the update every 5 years. Never finished.
Never finished. And guess what? Been involved with it 35 years, and guess what? 35 years from now, you guys will still be going through the same things over and over and over and over again. Why is it important for them to change? Why is it important for them to ever be mixing in this, putting their finger in the pie, stirring it up, shaking it up, so to speak? Because is medicine static?
No.
No. Evident medicine is dynamic. It changes. As people's lifestyle changes, medicine changes. What was good, golly, go back when Brian and I were practicing in the field, and the biggest call we had, Brian, you remember those brontosaurus bites we'd get, and those pterodactyl bites? Yeah. Back when dinosaurs ruled the earth. Yeah, those were interesting times. But
real trauma.
Yeah.
Caused by real cars made out of real metal.
That's right. No plastic involved.
By real men.
By real men. Yeah.
I will tell you that the world has changed so much.
Oh.
Car wrecks back then, people were hurt all the dang time, and now people step out of a car that back then would have been the end of their life.
Yep. And then,
it's just amazing to me.
Go back and look at this. Remember this? You have to give 4 stair-step breaths and compress at a rate of 1 compression every 60 seconds.
Hey, did the stretchers have wheels back then, or had they been invented yet?
We just slid them around on logs. We just had to keep taking the back log and putting it to the front.
There you go. That's how we kept moving those pyramids right up the way there. Yeah. And then we had you get four amps of sodium bicarb. Every patient got 4 amps of sodium bicarb right off three or four right off the bat.
You know, and it's funny because we talk about how, and it wasn't organized and it was chaotic and people were really bad hurt, but we never dealt with the disease processes that you guys are dealing with ever.
No.
I mean, it was, good Lord, if you didn't come back with a little blood smeared all over you, just really weren't on a call. And you didn't have any real pride about yourself. You'd almost just rub it on you like a war paint so you could say you done something.
Well, that was the run this morning, and this was the run over here this afternoon, and that was that woman that was bleeding. Yeah, had it on her uniforms. Went to the restaurants like that, you know? Gosh. Strange, strange times. I guess we did okay. We made it to the end. Made it down here to this part anyway. But evidence-based guideline has changed. You know, I told you, 3 amps of sodium bicarbonate and an epinephrine right off the bat. Well, that was right off the bat, you know, that was first things we did with ACLS. And nowadays, you wouldn't even think about that. You got epinephrine, yeah, but no bicarb until you get blood gases or you consider blood gases, you know. And so things have changed for the better, I might add. And it's evidence-based that pushes it that way. American Heart Association comes up with an idea. Hey, I got an idea. Let's give high-dose epinephrine. Yep, that'll work. So they come up and they researched it. And for a while they were thinking, oh, yeah, it looks pretty good. Yeah, it looks pretty good. And now they're going, no, they don't look so good now. Don't do high-dose epinephrine. Then I don't know, some of y'all may have gone through the nifedipine. You remember the nifedipine thing they used to do? Punch a needle in a nifedipine capsule and squirt it underneath their tongue?
Oh, we did that all the time.
Yeah. And these young paramedics are going, they did what? Why did they do this? You know, used to equipment came out and somebody would go, you know, that looks good. Why don't we buy that and put that on the truck? Never did question, why do we use something like that? And that's why we had things like, golly, let's see if I can find one of them out here. Wait, I better not do that. I better disconnect first. Stop sharing. I don't want that out there right now. Just thought what that says. Yeah. Yeah. Some of y'all won't remember this. Some of y'all will. But who in the world come up with this? That it would work?
Thank God you didn't type that in and show us the first result that came up.
Yeah, it came up a little wanky, should it be? But you can still buy these in Canada.
I'd say go buy one if you want to break a tooth.
Oh man, I had to think about putting it in there. But yeah, look at this. And these are the people that have had it put in and they've had to pin their teeth back in. Oh yeah. And they used to make us, the health department required us to carry one of these things. You remember that, Brian?
Yep.
The mouth gag screw, making a physician of whatever. I don't know. Anyway, yeah. You guys are looking at this going, that's torture. Who in their right mind come up with that? Somebody sitting somewhere thought, hey, that might be neat to have. We got to have one of those. And look here at the teeth. I'm sure that caused all that. Yeah. So, but you go back and you look at this thing right here. The good old-fashioned SAM splint. If you go back and do the study of this thing out here actually came about from a paramedic sitting on a commode folding a Wrigley Spearmint gum wrapper. And he folded it enough times that it got it stiff, and he went, I bet you that makes splint. And you know what he does now for a living? He don't work
Collects paychecks.
He don't work the ambulance no more. He works for his own self, and his name was Sam. That's, so yeah. Now he's got the Sam tourniquet, junctional tourniquet that he's done out there. This guy's just rolling the dough. He ain't working. He ain't buying them. He ain't working on ambulances anymore. He might be buying them. But anyway, well, guys, any questions? Anything good for the order? It's 4 o'clock. I think I did good for 9 hours. I got 8 of them in, right?
Harumph.
I think you did pretty good there.
We could go back and watch some more video, I guess.
No, we're good.
I don't think that's called for.
It was a good day of learning.
I know Todd would like that, but
Todd would like that.
He's
Todd
a damn
is into
teacher.
that
You
stuff.
know how they are.
Yeah, they like
No,
it.
I'm satisfied, KC. Good day of learning.
You've had enough of me, right, for one day? Oh, me. I do miss those days in the classroom. But I wouldn't keep y'all here 1 minute longer than I needed to. Okay, let me make sure. I got David Bell. I got Jason.
Yes, sir.
I got Highland. I got Jacob Moore. I got Stephen. I got Mr. Parton. And I got Matthew. Oh, I got Brian Unruh. Did I not call your name Unruh? I didn't.
No.
I better put you down here.
I think I was actually scheduled for next week.
Well, I'm glad you come this week. Of course, you can always come back next week if you would like. I mean, if you're not into pain and suffering.
Well, you do. I can always learn, I assure you.
Oh, I can too. And I learn listening to you guys. I learn more from y'all than I ever taught y'all. But I got you down. So.
Roger.
Well, I haven't heard of the National Guard being activated and sent to Washington. So I guess we're still in good shape. We're still a country of laws and unions.
I just want you guys to know I have, I made a bug out plan for deep dark Newton County, and been hauling stuff over there all day. That's when I turn off the camera. I'm taking another load to Newton County and getting ready to go, hide.
If you got a compound down there?
I wouldn't call it that.
Oh, okay.
On the computer where everybody can hear it.
Wait a minute. Where's that? Okay.